Good morning, everybody. Let me ask folks to please take your seats. Thank you very much. Thank you very much for joining us today. Welcome to our forum on AI and healthcare. I am Cecilia Oregón. I'm the Executive Director of the Institute for Health Policy, and I'm going to be the MC today. So at the Institute, we host events and publish information to help shape policy and practice and explore ways to promote high-quality, affordable healthcare and support healthy communities. Today's conversation builds on last year's forum on AI and healthcare, and today will center on the question of trust. So 2 years ago, Pew Research conducted a poll that asked people how they thought using AI to help diagnose disease and recommend treatments would affect outcomes. The poll found that opinions were fairly evenly divided, with 38% thinking that AI would lead to better health outcomes, 33% thought it would lead to worse health outcomes, and 27% thought it might have no impact either way. And another survey conducted last year found similar results, with 26% of people saying they felt optimistic about the use of AI in healthcare, 26% feeling concerned, and 27% feeling uncertain. These findings highlight some of the questions we'll be grappling with today on the future of AI in healthcare and the role of trust in that future. So at today's forum, we'll hear about exciting new AI innovations that are emerging and that have tremendous potential to improve health and healthcare. We'll hear the perspectives of different stakeholders on trust and consider how to build and maintain trust across the AI lifecycle. And we'll hear about opportunities to ensure that the benefits of AI in health care are broadly accessible. Across all these themes, our speakers will discuss implications for health policy. We've assembled some incredible leaders in health AI, and we're looking forward to today's conversation. We want today's conversation to focus on the topics of greatest importance to all of you here. And I want to thank those of you who submitted questions in advance. Our moderators and panelists have seen the questions and will be making every effort to help address some of those throughout the day. In addition, we'll have an exercise to help identify the questions that are top of mind for you now. And the IHP team will share those with our moderators as well. So it might be helpful for you to start thinking about those questions that you walked in with today. A few housekeeping items before we begin. I want to thank everyone in advance for adhering to our code of conduct and supporting a fruitful conversation with space for all different voices. To access information on today's event, there are cards at your table. They have information on how to connect to the Wi-Fi and a QR code that takes you to the webpage with the agenda and speaker bios. If you're using social media to share posts on today's event, you can mention us using our handle at KPIHP and hashtags like AI and healthcare AI. We are recording this event, so please silence your devices. And if you have to take a call, please do so outside or ask one of our staff members if there's a space that you could take the call in. Restrooms are located behind the screen wall and down the hall to the left. And in case of an emergency, which we hope there will not be one, the exit is located right behind us, where most folks came in today. So I would direct people there in the case of an emergency. So with that, I want to welcome to the stage Dr. Vincent Liu and Mr. Bakul Patel for our opening conversation. Dr. Liu will introduce Mr. Patel in just a moment. And as both of you come up, Dr. Liu, I'll tell the audience a little bit about you. Dr. Vincent Liu is the Chief Data Officer for the Permanente Medical Group and Kaiser Permanente, a pulmonary critical care physician and a senior research scientist at the Kaiser Permanente Division of Research. He leads programs in using advanced analytics, data science, and responsible AI to improve care delivery and patient outcomes for the 4.5 million members of Kaiser Permanente Northern California. Now I'll turn it over to you, Dr. Liu.
Great, thank you so much. Welcome to everyone for this. Welcome to everyone for this very exciting day, where we're talking about AI, innovation, benefits, and trust. We're going to be spending some time chatting with Bakul Patel, but I thought I'd just get us kicked off with a little bit of an intro. I'm going to start by describing kind of like what is AI, and I'm going to use a simple version, and I think Bakul will go into more depth. I think of it very simply as breaking down the terms artificial and intelligence. Intelligence is the capability to achieve complex tasks, and artificial is non-biological systems or machines. So in my construct, in this simple construct, artificial intelligence means machines that are able to accomplish complex tasks. And we've come through a number of epochs or generations of AI. I would say the reason that it's come to the forefront over the past couple years is because we've come from a place in which it was narrow, defined, trained, so that every AI instrument or tool really focused on one objective and could do that extremely well, whether that was predicting an outcome or evaluating one modality, like a chest X-ray, for example, to identify a hidden feature like a pneumonia or a device. But the place that we've come to is where AI is now broad, generalizable, even multimodal, where it can integrate lots of different types and modalities of data and is not trained on a specific task, but has shown facility with being able to accomplish, again, complex tasks that it wasn't trained on. Importantly, in KP, we also use the concept AI as augmented intelligence. And so, again, the reason we think of it as augmented intelligence is because it places people, patients, clinicians, and communities, rather than algorithms at its center. And for today's conversation, the trust imperative, I think that's incredibly important to remember, that we're thinking about AI and its impact on some of the most human needs that we have. Healthcare, well-being, the ability to live a life that's fulfilling and where we're able to increase health span. Now, when it comes to AI and healthcare, we'll talk about this all today. There's many, many diverse applications. There's things like automation in the back office, improving, some of the administrative aspects of care. But I think what's really exciting is the opportunity for AI to improve things that really matter to patients, to clinicians, and communities. Earlier diagnosis, new drug discovery that can fundamentally change the course of disease, precision medicine, and information synthesis. So pulling together all of those diverse pieces of data, some which are very complex to piece together in a cohesive way and do that quickly. And then finally, to use all that information to generate new insights that help us improve that healthcare partnership that we're in together as clinicians, care teams, patients, and communities. How is KP using AI today? Well, really, AI is part of our objective to achieve our overall mission, which is to deliver high quality and affordable care, to improve the health of our members and the communities in which they live. So AI is really part of that, but again, aligned with our overall mission. I'll give two really quick examples. One is something that we put in more than 10 years ago, Advanced Alert Monitor. So we knew that a small percentage of patients in the hospital deteriorate and end up in the ICU. And these patients are often giving off signals that they're deteriorating, but they can be missed in the course of care. By using a predictive algorithm in order to stitch those things together, we can surface those insights earlier, bring together a care team that does a reassessment of a patient, and even ask fundamental questions, like if you were to worsen, would you want more aggressive or invasive care? Because up to a quarter of our patients in the hospital do not want life support therapy, do not want to be resuscitated. So really, again, focusing on that human-centered, patient-centered orientation in order to improve care. But with the use of that tool, we've seen that it's saving 500 lives per year across our hospitals in Northern California. Another example is in the generative AI space, which is the ambient AI scribes. That's really taken the industry by storm. Simply put, there's a microphone on a smartphone, protected and private and secure data, where it takes the role of taking notes and synthesizing a conversation between a physician and a patient. What we found is that it improves the physician-patient relationship. Physicians spend less time locked in on documentation in the computer. It improves burnout. The industry has shown that, leading to a more sustainable workforce. And in aggregate, it saved our clinicians tens of thousands of hours in time that they spent outside of work in documentation. So those are some of the ways that we're thinking about AI, augmented intelligence, as helping to support our mission of high quality and affordable care. And now we're going to hear from Bakul Patel, who is currently the Senior Director of Global Health Regulatory Strategy for Google. And he focuses on building a unified digital health strategy aligned with global regulatory needs, with a vision that Google will help to realize the potential of digital health to herald a new era of healthcare. Importantly, Bakul spent time in foundational ways at the FDA as the Chief Digital Head, Digital Health Officer of Global Strategy and Innovation, as well as the Director of Digital Health Center of Excellence. He's coined important concepts in the field like software as a medical device and other aspects which have become central to the way that we think about regulation of AI in healthcare. And with that, I'll turn it over to Bakul.
Thank you. And first of all, thank you for having me here, and I'm really honored to be speaking to you all. I wanted to just tell you how excited I'm about where things are going and where things can go. Of course, we have to be guarded with, how much do we trust? Can we detect those things that are wrong? Technology is not perfect yet. It's getting better by the day. I just want to sort of add to what Vince just talked about, the epochs of AI that we're thinking about. Let me add like a slightly different perspective. We used to think about experimenting and then coming up with some sort of formula that will be programmed in, and then the next phase happened with machine learning, where we basically took our experiences and documented experiences and data that sort of came from that and turned that into something that we can repeat again. That's what we call the second epoch. And the third epoch is generative AI, that basically ingesting everything that we have ever written and trying to find connections between what we could say. Nobody, I think, at least the people I've talked to, knows how it comes up with coherent statements that we all like to see from these tools, because the technology is so unexplainable to some of us. So I think this is where you need to sort of understand where things are heading. Things are a little bit unknown. We cannot anchor on things that we knew that we need to know everything about technology. That's the caution part, but the promise is also incredible. We went from a linear inquiry structured way of looking at things to more of a curious inquiry that where we can actually ask the things that we are thinking, and we can get this answer. And if some of you may have used Notebook LM, where you just put a document in and you just ask questions in a document as you're reading, as opposed to reading the document. So it completely flips the script on how we interact with content and how we interact with information. I want to share a clip that sort of exemplifies this a little bit, and a journey of a dad, a recent dad, and it's called The Thomas' Story. If you guys can cue up the video.
I had no idea what Alexander disease was. Typical life expectancy is 5 to 10 years. There's no treatment, there's no cure, there's nothing we can do. And I fell to the floor. You have all of the emotions. You're angry. It's unfair. What has he done? Like, he's just 7 months old. I mean, I love him so much. And to just accept the fact that, you know, we'll just wait and see and do nothing is, that is not an option. There's always something you can do. The first thing you do is search, like, what is Alexander disease? Because you have no idea. Okay, Alexander disease is caused by a mutation of the GFAP gene, which makes a GFAP protein in astrocytes. And then you're like, okay, what are astrocytes? So you start hearing all of these words, like myelin and oligodendrocytes. Like, I don't even understand the language. When Gemini came out, the really lovely thing is that it can read PDFs. So it can help me analyze and understand scientific papers that are incredibly dense, could be 20, 30 pages of technical language. And I can go, just summarize this for me, please, and help me understand. Then I get a very helpful top-line summary of what this talks about. I think that's where I started to get a bit of a sense of what was going on. I understood, I guess, that there are some parallels between Alexander disease and Alzheimer's. And there's not that many people working on Alexander disease, but there is an entire army of pharmaceutical companies, research scientists, and everyone in between working on trying to fix Alzheimer's. You realize that suddenly there is a bunch of people out there who work on things that they themselves don't know might be really relevant to Alexander disease. So I can literally take all of these papers and I ask Gemini, can you help me understand this paper on Alzheimer's? Thank you. Can you help me summarize this paper about Alexander disease? Can you bring the two things together, please? How is this relevant in that? Oh, okay, this might be relevant. Hey, Gemini, can you help me write an email to the author of this paper outlining how their innovation might be relevant in Alexander disease? And it's like, sure, can. I literally send an email on Friday late afternoon. Monday morning, I get an email back from this professor in New York.
That email really caught my attention. I have to admit, we've never heard of Alexander disease before. You know, I emailed him back saying, like, I think this could potentially be something that we could test.
And now she is working on Alexander disease. They're literally in the process of arranging the experiments. That is my...
So this person took the curiosity to the next level and actually started an initiative for researchers who were already working on adjacent disease and sort of make that. So to me, this is sort of the way of putting power to patients, as Vince was talking about, directly. In this case, a dad, an engineer at Google, didn't know anything about Alexander's disease and able to turn that into something in a very curious way. And that's the power of technology. I want to show a really quick, a second dimension of a program at google.org that was started for veterans who are experiencing suicides, or actually we saw there's many veterans commit suicide. So taking that and turning that into a solution that can help those veterans was something that google.org did. So can we share that video?
Well, my buddy Ashton died, and so now I'm kind of bummed and not really wanting to be around anyone. Oh, wow. So sorry to hear that. I'm here for you if you need someone to talk to.
I really appreciate it.
I really appreciate it.
Personally, I have lost over 50 friends because of the simple fact that they didn't have anybody to pick up a phone and listen to them, you know, hear their outcry. Technology like this just opens up for there to be dependence, you know, on other individuals.
Having that communication opens the door for the healing process.
As we launch Home Team, every part of the product has veteran hands on it.
Everybody really came together to try to build something here.
I really hope that we have made a dent in reducing stigma among service members and veterans.
We're not just creating a product that serves a need, but that is connecting people to other people.
The big hope here is to save lives.
So in this project, AI was used to train veterans to talk to other people, to connect with the community, to make sure they have the support in the way they wanted support and not just prescribed one way of thinking. For me, this technology that we're entering into is opening up doors that didn't open before. We're no longer thinking about, oh, how should I understand this table of data that we have in front of us? Instead, we can ask curious questions. I have many other examples, but I think to be very germane to, you know, in a hospital setting, a simple example was nurse handoffs. how can we make that even simpler and make sure that the transaction that happens between shift 1 to shift 2 and shift 2 to shift 3 is seamless and nothing is lost in the transition process. I think those kind of solutions will actually bring value and bring trust before we get into the diagnostics using generative AI or therapies using generative AI. There's a lot of discussion around mental health today, and we know these tools can actually create harm, can actually also, if positioned right, can actually create value, just like we saw in the veterans case. So I feel like there has to be a balance as we move forward. And as we think about policy, we need to start thinking about what is the right levers, what are the right guardrails, how do we train people, and so on and so forth. Maybe I'll turn it back to you, Vincent, just we can have a conversation around, where should we go from here, and just discuss what are the trust issues and what are the sort of opportunities that we can sort of leverage.
That's great. Let's go ahead and do that. I'm blown away by the surfaces that Google has in its kind of entire umbrella, not only within Google, but within the larger enterprise. People may think of the search bar, but we're also talking about YouTube, we're talking about wearables, we're talking about health-specific companies that are even at the basic or translational stage. So across, and when I looked it up, I used Gemini and looked up how many health-related queries does Google, is it estimated that Google gets every year? And they estimated the number in the trillions.
Yes.
So when you're thinking about a surface that's that broad, not to mention partnerships that you have with health systems and health-specific companies, how are you thinking about trust? And, kind of aligning global regulatory considerations across that really, really diverse, heterogeneous, and simply massive scale surfaces.
Yeah, I think what attracted me after FDA at Google was its mission to help everyone everywhere around the world was sort of the key driver for me to join Google. And when I got there, it was sort of important for me to understand, how does that happen? And then I dug into this. And to answer your question, there's a lot of work that goes into making sure that the information that is provided to the user when they're asking a query is grounded in something tangible. We often anchor ourselves on the WHO guidelines. We anchor ourselves on health systems guidelines, and make sure that those are surfaced first. That is not blocking other things, but also surfacing the first relevant things. And that happens across search, that happens across YouTube, it happens across other surfaces, like even maps for that matter. Finding the nearest facility is actually a feature that sort of exists today. One thing I would say, again, going back to the numbers, the trillions of queries that comes across the world, what we have seen shift is with the advent of generative AI and inclusion of that into our products in AI overviews in our AI mode, we've seen people ask longer queries, more conversational queries, as opposed to just keywords. And we all know, I'm pretty sure there's a diverse level of feedback you will get from a regular search if you didn't use the right words, if you didn't know how to frame it right, and you get different levels of responses back from the search. But now, with generative AI, I think that has sort of increased the access of information to many people who are just able to just talk in the way that they would normally ask a curious query to another person. And that is sort of the power, I feel, that's sort of happening. And the question about how do we think about, in generative AI space, about making sure the health information is surfaced in the right place, in the right way, being sensitive to the fact that, there is a downstream effect of a user undertaking something that's shown on a screen and taking action or inaction on whatever the next step in their health journey is supposed to be. We take really, really good care. In fact, one of my team and the health team at Google spends a lot of time making sure the models are trained and there are guardrails in place that don't allow people to sort of assume that's the only thing that they have to do or think about. And that is because it's a general purpose tool. It's a general purpose query that people are making, and not specific for a particular, like you said, not diagnostic or not specific, like how do I treat X or how do I manage Y. I think it's just about information. And that's kind of how we think about internally.
Mm-hmm. I'm wondering about whether there's a tension between kind of the pace of innovation and then making sure those guardrails are in place. Feels like with the pace of change in AI, everyone is kind of building the plane as they fly it a bit. And so how do you think about that, particularly given the potential impact of AI for benefit? You know, the information asymmetries and other kind of, things that have blocked patients from getting engaged in their own care or have blocked information from rising to the surface where it can then be, acted upon. How do you guys work through some of that tension?
So I think Google is a consumer-first company. So the way we think about this is consumers need to get access to the best information. In fact, there's a mandate for across Google to make Gemini the best for health in period. And that sort of gives a mandate to everybody working at Google to start thinking about users, which is the center of the universe for Google. And think about patients and health users, very different bar to start thinking about it from that perspective. And what we have done is making sure that the empathy that the responses come back with, the way it's proposed, where the response is proposed, actually matters quite a bit. And it's not just about, when somebody asks a question, I have X, my knee hurts, what should I do? It's about explaining why, and usually in care, as you know more, there's more than just what the person asks, right? That you have to look at what the person is really feeling, what did they do in the past, et cetera, et cetera. And I think that missing piece is totally considered in the response that was given by the tool. And we're getting better at sort of making sure that we're understanding the user's intent and also sharing with them some of the things at a very high level in terms of like, look, you need to think about this as an information tool set, that you should take that into consideration and go talk to your doctor. You'll see tools come out by various players that's going to make the interaction between, before the encounter happens with the doctor, the information that the patient needs, information that the doctor needs, and that friction will be reduced with this technology. And I feel like that's the up level that's going to happen in this space.
Mm. So we've talked a little bit about Google's interaction with users and the users being kind of folks out in the communities. What about partnerships that you have with health systems or clinical groups? It feels like there's a lot of work happening in that space. Do you have a different type of regulatory schema or guardrails in place that differ from kind of your general purpose services?
Yeah, I think, Google, except for a few areas in the Fitbit world and the Google health hardware world, we don't intend to sort of make regulated products. We're great at enabling others to sort of make products, may it be in retail, maybe in automotive, maybe in healthcare. So I think the way we sort of build platforms is kind of what we're good at Google. So our strategy always has been, how do you get people to build those vertical answers in the most sort of easy way? So for example, I'll give you, this is not new. Many years ago, actually even continuing, Google has the biggest contributor to open source community. We put out a dermatology model that's a foundation model. Instead of training the model from scratch, you can train the model using this foundational open weights model to reduce the time it takes and the data it takes to train the model for that particular thing. We did similar things for mammography. We did similar things for diabetic retinopathy and so on and so forth. There's many other things sort of gives people, and the Google research actually spends a lot of time thinking about how do we enable people to sort of not struggle to the first 8 miles and only worry about the last couple miles.
So we've talked a little bit about the epochs of AI, how we've gone from more narrow, trained, defined objectives, and then now to more broad, generalizable.
Yeah.
You've actually written about kind of the concept of regulation with clinical Gen AI and how we may need to reframe the way we think about that. Would you talk about that some?
It's controversial, I'll just say it up front. And the fact that I say it's controversial is because I couldn't think about, spending about 14 years at FDA, I couldn't think about another way to sort of look at this generative AI as a tool that is almost getting closer and closer to mimicking intelligence like we as humans have. I'll just give you a couple examples. It's kind of, tongue-in-cheek, but I'll say, humans also hallucinate, so does this AI. We also make up things, so does this AI. We can't really tell how you came to an answer when you ask a person because they have connecting the dots in their head and experiences and the learnings they have over the years. It's exactly very similar to what this generative AI is doing today. We really can explain in a simple way that humans can understand what goes on with this large language model, especially when you think about trillions parameters, which is like trillion powered equations. We won't even fathom what that means, right? Even if you spend a lot of time. And then you start thinking about the next epoch of AI, which is folks are talking about AGI, which is
explain what that is.
Oh, I'm sorry. Artificial general intelligence, which is supposed to be a self-learning model that is not trained from what has been thrown at it, but it's as humans we are going to learn over time. And there's a bunch of papers written in the scientific communities that talk about the current LLM models are only going to take us this far. The next generation of models will actually take us to a place where it'll be just like human brain. We absorb things along the way. And when that happens, I don't know when that's going to happen. Some people predict 3 years, some people predict 5 years, but it is going to happen since people are working on it today. As we think about intelligence, and going back to the paper question, I think there's a couple things that current regulations or current structures don't quite work. Knowing when to put a thing in the market requires us to understand when good is, what good is, which means we need to know what measures to sort of measure it with, which means we need to have the metrics all established and standardized, and we all understand, we can all agree that's the right metric. With Gen AI today, I don't think we have that. We don't know how to measure empathy, tone, and there's probably the academics in the world probably go like, yes, we can do this, but can we really? I'm not sure. Can we actually standardize it? Probably not. So I think the first threshold of knowing that we can send something to market because we know it's good and doesn't hurt. So we have to get uncomfortable with the non-preciseness of this. So that's number one. Number two is how when we see something go wrong and when things actually affect people when something goes wrong are two different distinct events in time that may happen. I'll just say it one more in a different way. When something goes wrong and the symptoms that shows up, the cause of it may be in a different place at a different time. That connection, the causal relationship of when something went wrong, finding what went wrong, is going to be very different. And because it's a system that we think about. So that's the second thing. And third thing is, how do we start thinking about what is it meant for? And we are looking at this technology that's based on large language models that are going to be verticalized for radiology or cardiology or other things. But the foundational will be very the same. Then we'll have the small differences. So how do you sort of understand what goes in, what goes out? And we just don't know what inputs look like, what outputs look like, and level of control that need to be put in. So you have this entire system that we currently know is questionable, even from a liability perspective. Like, who should we hold liable in this entire chain of things? The current systems rely on one person building it, one person liable, one person responsible. And I think the systems approach today does not, with the technology that we have in front of us, don't quite allow for that. We can, of course, force fit a bunch of things, may not actually matter. So with that in mind, the paper I wrote last year was basically saying, can we think about this as how we, quote unquote, regulate humans? We send them through schools, we take some exams, we monitor them along the way. Even working professionals that, later in their career are still evaluated every year by their bosses to understand whether they're performing. And if they're not performing, they're actually penalized, and so on and so forth. So I think there's a structure that we know. I don't think we have the threshold established for that structure. I would say we should work on those, because if we were to send an LLM to a USMLE test, it can surpass what humans can do today. But is the test made for humans should be the same test made for LLMs? Probably not. So should we think about that separately or differently is kind of what the paper sort of proposes. And that was an initial thoughts on the paper that we wanted to share to get the conversation going. I think we need a systematic approach to a systems-based sort of solutions that's going to be in front of us. And I'll leave you with one thought, right? I think it's going to be important for us to start thinking about observing failures as opposed to reporting failures. We know there'll be many eyes along the journey of the use of this AI that can provide insights into whether it's working or not working, as opposed to just one person or one entity or one organization knowing. So I think that is going to be really, really important to sort of consider as we move forward.
Great, thank you. And that kind of fits with my, I use this kind of concept in my head of AI moving from being a tool to assistant to a colleague.
Yeah.
And how does one judge a colleague and what their proficiency is on certain skill sets is very different than, saying that we're going to evaluate, the precise, use of that tool.
Exactly, yeah.
Okay, with that, we're actually going to turn this time now to the audience to make sure that we're hearing your questions both for this session as well as for the sessions that we're having throughout the day. So we're going to have an interactive time at each of your tables. So for those of you who are not yet at a table, feel free to come and sit at one of those tables. And what we want to do is really make sure that the questions that are in your minds, at the top of your minds, are brought to bear on this conversation. So first, I think there are either index cards or notepads at each of your tables. And what I'm going to ask you to do is just take a minute to individually question both for Bakul, for our other presenters today, that's at the top of your mind related to AI innovation, benefits, and trust. So go ahead and take that time to do that now. All of you. Okay, now what we're going to do is actually interactive at each table. We want each table to essentially agree on the most pressing question, the most interesting question from your tables. So for the next 15 minutes or so, what we'd like you to do is work together with your table. Start off by introducing yourselves to one another briefly, and then also describing what your question is. And then together as a table, coalesce on kind of one, again, the highest priority, the most interesting, the most important question from your table. Folks from the Institute for Health Policy will be circulating to answer questions or to help you, and we'll be collecting those and make sure that they're part of the conversation that we're having here today. So go ahead and introduce yourselves and begin thinking through that question. All right, everyone. It looks like we're collecting some of those questions. Hope you had a chance to interact at your tables. Before we bring some of those forward, I wanted to ask Bakul about what he sees in terms of the context of the U.S. versus the global regulation. We've seen from the president, the AI Action Plan, that healthcare is one of those domains that has traditionally been too conservative, behind on our ability to deploy AI, and then also even the concept of a try-first approach.
Yeah.
But we're actually in the U.S. situated in a spectrum of regulation around the world. Would you describe kind of what you see as how our regulatory environment compares to other countries, and what risks and benefits that may have for us in over the next decade?
Yeah, let me give you a little bit of a bird's eye view of where the world is. I think U.S. is to be the most stringent, well-respected in the world for regulations. And somewhere in the last 15 years, it sort of took a very pragmatic approach, at least from the FDA perspective. And then the EU AI Act happened, and we all know, GDPR happened, we all know, where EU sort of in the world became the first, most rigorous, most burdensome regulatory infrastructure. Then you have the other parts of the world where the meeting the patient needs and user needs and patients in the healthcare journey was a challenge from get-go. So I feel like to your point, Vince, I think this is a spectrum about how much regulations, where it's applied, and so on. My perspective, I've been talking to folks in a few countries. Some countries have started thinking about how do you try first before you regulate, as opposed to regulate before you try. I think we are squarely in the middle of that pack, as in U.S. There are certain countries on the other end of the spectrum where they're thinking about regulations, or they have existing regulations that they're going to feel like that's important to protect some of the the citizens of their countries or their unions. And then there are countries, I'll name a couple, are well poised, controllable in their own sense. They're smaller, like Taiwan, like Singapore, even the countries in the African continent are thinking and even the Middle East, are thinking very proactively, because they don't have anything to break down. They don't have any infrastructure to take down or rebuild from. And I feel like they are actually in a place where they can try and then figure out what the regulations is adequate. I think we are squarely in the middle in the US. The folks in the EU, even the EU AI Act has happened. Even the states within the EU Commission or the Union are actually starting to think about, should we be trying first? So I feel like we are squarely in the middle of where AI will be regulated. I see the global trend towards this journey about allowing technology to flourish before we actually start actively regulating. So that's kind of my sense. I think I'll say this out loud. I think what I'm noticing, every country is thinking country first in terms of we need to be first in this race, this proverbial race. I don't know what they're racing, but they're racing into making sure that technology is available for their patients and the users of their country. But this is, I hear every government trying to be, we want to use AI to enable better healthcare for our citizens. That has been sort of the consistent thing that comes across. When I talk to even the member states in the European Union, I hear the same thing. But the law says something different. But that's a different story. I think they'll figure it out themselves. I think you've seen the same thing in the AI action plan that this administration has put out. It has the same kind of underlying tone of making sure that we are enabling or leveraging this phenomenal technology for the future of healthcare.
Great. Okay. I'm going to just start reading here. Bakul, you mentioned liability. How do you view liability in AI agent interaction with patients? Is the conversation or query medical advice in the same way as a physician consultation? If a general AI radiology system gives a wrong diagnosis, who is liable?
So
easy one for you.
Easy one. The general radiology diagnosis is actually regulated today. I mean, plenty of companies make this radiology software that detects things on an image or diagnoses certain things that are happening in an image that AI can see. That is actually not the interesting question. The interesting question is when medical advice is given, just mimicking a care provider, where's the liability? I don't quite have an answer for that because we don't have the American Medical Board sort of regulating some of that stuff. And this is my point of the paper I published, right? I think we don't have infrastructure or systems in place that shows, oh, you're allowed, or this application is allowed to give advice, or this is not, because it hasn't passed this threshold. I don't think we have that yet. I think we need to create that. Others will be in this constant struggle for finding the person in the dark, and we won't find it.
And do you think partnerships with organizations like the board, professional boards, or the American Medical Association or others is going to be important to getting to that place?
I agree completely. I mean, we have to. I don't think we have a choice. At least from my very biased perspective, I would say we don't have a choice to not engage the non-traditional people in the healthcare systems, the non-traditional regulatory folks, but they are in the way providing some sort of assurance along the way for people when they're providing care. Just AMC, for example, could be a player. Joint Commission could be a player. EMA already has things that they can do. I mean, so it's the role that we have taken for granted. I think we need to pull them into this conversation. Otherwise, what we'll do is we'll not have the right infrastructure in place.
Yeah, and let me also include the certifying boards for nursing professionals and therapists of all kinds. The allied health professionals, the entire care team. Yeah. Okay, excellent. What level of explainability and human-in-the-loop oversight should we maintain even as AI becomes a colleague?
That's fascinating. It's fascinating because I actually, just last week, I was at a conference and I was just debating this with somebody. And this person just reflected back to me like, how about if we stop talking about AI in the loop and just, humans in the loop and just talk about AI in the loop? I think that's where we are. Like if we start thinking about AI in the loop, it just puts the right framing. I love that because I said I'm going to use it and use it forever because I'm going to stop using human in the loop question. I think if you don't think about it as an AI in the loop, we'll be missing out on things that we don't normally sort of think about. I missed the first part of the question.
What level of explainability and human oversight should we have?
I'm going to be really controversial now. Explainability is made for humans to understand what the AI is doing. Now, you could ask another human to do the same thing, and you could probably get a reasonable answer. Is that what we think about explainability with generative AI? I'm not quite sure. I think people have various degrees of understanding or expectations of explainability. I think it's completely fair to say, oh, it's explainable because it ingested this amount of data, this type of data, hence it sort of matches the pattern of XYZ than the data that was trained with. That is explainable. I can understand that. But when you ask about explainability for generative AI, it's a very different question. You really can't explain it that way. So you have to sort of think about, now you'll see pretty much all the AI tools have a thinking mode. If you guys haven't seen it, if you're curious, click on the thinking mode. It actually tells you what it thinks. To me, that is explainability. So and that is just recent, right? It didn't happen 9 months ago. It started happening, recently. I think this is what will happen for us. So I think we're going to continuously try to sort of understand why that answer was given and why it was sort of proposed in that way. And then if you think about it from that perspective, then we are getting away from this. We need to understand every detail of how the answer was coming to. I think that is less explainable anymore than actually just understanding what thinking went into. So I think we are going to sort of see this evolve as well as we start going more and more into generative AI space.
And just going back to the former point, Bakul, fill out for me the AI in the loop concept. Do you mean where does AI fit into a human process today, or do you mean AI as the arbiter of or judge of a process that's going on?
So I'm framing this. If you think about just human-made processes for humans, we made how to interact with another person, pass this baton over, and the baton takes over. And now we have AI in the loop that can sort of fill in some of that. The nurse handoff was a very simple example. Just think about it that way. But if you think about every process, every organization, every healthcare interaction it's made for humans by humans. We'd never thought about made by humans with AI in the loop. And when we start leveraging agents, for example, and you mentioned that, you start sort of giving that autonomy of go search this thing and come back with an answer, or go query this part and come back with an answer. And it's going to be an equation that comes into play when I'm going to make the final decision. So I think the decision points and everything, all the things that we as humans don't really like to do or find it very tedious, is going to be that AI in the loop sort of process. And there may be some things that are low level of decisions making might be just handed off to AI. But there may be a place where we need to make the critical decisions. We need to make the most of the decisions. And I think the decision power may still be there with the humans.
And I think you're speaking to extract value out of AI, it's going to have to change the way we work.
Yes.
Rather than just be bolted on to existing processes today,
Yeah.
right? Because that's only just going to,
Yeah.
it's probably not, we're not going to be able to get the true value for human health
Yep.
and for the way that we can deliver care without changing some aspects of how we work.
Yeah, exactly.
Okay. How is Google preparing for the future with patients having their own health data and wanting to share that with Gemini in ways that are privacy-preserving and protected from discovery?
There's a lot of very deep thoughts going on currently at Google, very much so. And it's top of mind for a lot of people at Google. In fact, privacy is one of the key ingredients. I mean, if you look at the number of people who work on privacy in Google, is mind-blowing. And it's not because we just thought about it today. I think from the days of search and YouTube and maps, that has been top of mind. There's plenty of people who think about models trained with de-identified data is like the key foundation as we think about. Now I think we're getting into a space where it's going to require some more further thinking when we start thinking about when models start to have memory, it retains context. We are actually, you'll see some things that may have already, you guys may have seen this already. There's a personal health agent we are sort of trialing out for people where it's basically like in your domain, on your phone, on your device, maintain the information. Now you will see things transition to on-device LLMs built on your phone, etc. In your sort of control. So you'll see this evolve over time. We are very actively in that space today, and it's very much top of mind. And technology is also growing at that exponential space where when the models have more in your account, and when you log on to Gemini, you have your own control over your data. What are you exposing to? It's not going back to the model. It can't, because models don't learn that way yet. Eventually, maybe it's your personal model happens. But I think that's the challenge and to be seen as we move forward.
Just to follow up on that, I mean, within the healthcare domain, there's regulations like HIPAA.
Yep.
But then once data leaves that environment, they're not under one single umbrella, right? Like so, data security, privacy varies according to different, whoever has the data, like that de-identified data or whatever. What do you see as kind of the right innovation in that space from a regulatory standpoint to preserve that privacy and security?
I think enterprise solutions where your enterprise hospitals or healthcare systems can domain out their own enterprise, and anything happens within that domain should be still under the HIPAA sort of umbrella, right? I think I anticipate we need to start being clearer what those boundaries are. I'm not an expert in HIPAA at all, but the little I know, I think as the definition of business associates may need to sort of be clarified as we move forward, which data is available for models to use. And this may be another example of AI in the loop kind of conversation where when AI is in the loop, what's that business associate transaction that needs to happen, agreement needs to happen with the LLMs. And I'm thinking out loud here, but I think this is a place that we probably need to start observing and monitoring and seeing whether we need to sort of provide clarity. And the lack of not being proactive, we might actually be finding ourselves in a place where we don't think we need to be from a privacy perspective. And on the other hand, I think I've seen examples where people are throwing at personal X-rays and images into public domain tools. Like, not quite sure how that is handled, but the tolerance of the public is also changing over time, and we need to just be aware of what that tolerance is. I don't think the rules needs to be so stringent that doesn't allow people to do it, and if those mismatch happens, we'll find a short circuit or a bypass for users to sort of take control of themselves.
Okay. What are 3 strategies to overcome biases in healthcare AI? How are healthcare systems tackling that issue now?
I know I've been talking a lot about generative AI, but I think let's just put that aside for a second. I think there's, at least just from my perspective, I think there are 2 fundamental issues for biases. One is availability of data, diverse data set. 2, participating in providing the data set. So it's not just things are not available, but also people don't participate in providing the data. So there's these 2 factors sort of get us into a place where developers and innovators can't really break that barrier unless there is like an openness in sort of making sure it's value added to the table. So in my mind, I don't know about 3, but I'll tell you 1 would be really helpful. If we start incentivizing patients and users by not giving them few cents on their data, but also giving back value of how the data was used, how that data was actually advanced, whatever that was advancing, either it's cancer research or something else. I think that feedback loop, I feel like it's missing for a lot of people. And if we start adding value there, you're creating an incentive structure for people to share more. They can decide to share in the right format, in the right way, in right constraints. But I think that if we start unleashing some of that, I think we may actually be in a better place. But right now, there's nothing to give back value for anybody. In fact, some of the value is being held by people who think they have the data.
And related to that, I think one of Google's missions is to organize the world's information, and in that way make its tools available to a very, very diverse set of people. And how do you see that kind of that value proposition, returning value, or making sure that end users are deriving value and thus willing to participate in some ways in contributing to those data? How do you see that playing out, given that you've already overcome some of the traditional limitations to data access or insight or information insight?
Yeah, I think this is the big difference in where Google has been in the consumer-facing, providing information, and then the healthcare-facing. The healthcare-facing, right or wrong, we have HIPAA, and there's protections for personal health information privacy. That has been the divide for consumer technologies to sort of say, we can connect those two dots. I'm not sure we will be able to connect that, or I don't know, I haven't thought about it enough to say, let's connect what we've learned in the commercial world into the healthcare world. I'm not quite sure we've made those connections yet. I think you raise a really good point. If we were to do this, we've not just in Google, but just the advertising world have learned quite a bit about how to engage people in their shopping experience. Why can't we do the same thing for the healthcare experiences? So I feel like there's lots of this science and connecting of domains that can be happening. I think we need to bring, we in healthcare, I keep saying, we in healthcare, not we in Google, we need to bring other people's perspective and learn from other aspects.
Great. Okay, it looks like we've run out of time, so I'm going to end us there. Thank you very much for your insights, Bakul.
Thank you so much for having me.
Thank you, Bakul and Dr. Liu, for all of those great examples of AI innovations and thinking. I have a lot of notes scribbled here around value and feedback loops. So there's so much that we learned from that session. So thank you very much. And I do appreciate the perspective of all of you in the room and going through the exercise to identify, I think, really fantastic questions for our speakers today. So a huge thank you to all of you for participating in that process. So we will continue to explore trust in our next session from different stakeholder perspectives. And I'm going to ask our next panelists, Dr. Jain, Dr. Cordovano, and Dr. Nundy and Dr. Tripathi to come to the stage in about 10 minutes. And we will be taking a 15-minute break. So if folks could please be back here at 11:05 to get started, that would be great. So thanks very much. Enjoy the break. Thank you, everybody. We're going to get started now, so let me encourage you to take your seats. Again, thank you for joining us. I'm so glad that the last session sparked some good conversation in the room, so thank you again. And for those in the back, please grab your coffee and head back to your seats. So why don't we go ahead and then get started with our next panel. Our moderator for the next panel is Dr. Sneha Jain. Dr. Jain is a clinical assistant professor of medicine in the Division of Cardiovascular Medicine at Stanford University. And she also is the director of the Guide AI Lab at Stanford. Her research focuses on the development and responsible evaluation of AI tools to augment healthcare delivery and improve patient outcomes. And she works with the data science team at Stanford Healthcare to deploy and prospectively evaluate AI solutions across the healthcare enterprise. So Dr. Jain, thank you for joining us, and I'll hand it over to you to introduce our panelists. Thank you.
Wonderful. Thank you everyone for being here, and what a fantastic conversation already that we've had this morning. This next session is really going to focus on what does trust mean across different stakeholders within the healthcare system, and what's the balance between trust and speed of innovation? Do they work together? Are they sometimes slowing each other down? What do we think about that? And so to start off, and we'll probably do about 40 minutes of conversation here, 40 to 45 minutes, and then go to 20 minutes of Q&A, because I want to make sure that this is a dialogue and a discussion with the audience. You already have had such great questions, and I want to make sure that those are highlighted. So to kick us off, I'm actually going to ask each of you to introduce yourself and share what is most top of mind to you now. And if you could ground it in your perspectives, as well as your experiences with your organizations, that would be fantastic. So Grace, let's start with you.
Hi, good morning, everyone. I'm Grace Cordovano. I'm a board-certified patient advocate specializing in the oncology space. My day-to-day is working with patients and their loved ones from point of diagnosis through survivorship or end-of-life care planning. I've had the privilege of working with a few people here in the audience on the National Academy of Medicine's AI Code of Conduct project, as well as I'm a co-author on the Light Collective's AI Right for Patients, and most recently partnered with Google and the Digital Medicine Society on the launch of the AI Implementation Playbook. What's top of mind for me? When I think about this, it's recognizing that patients and their families are end users of AI. And what do we do and how do we help patients and families and communities when there isn't a doctor or a nurse in sight, when their phone calls and messages are not returned, when they're sent home to die, when they don't have a diagnosis, and when they're suffering and they want to be engaged in their care but can't get there. The last 3 years using AI tools that are openly available have been transformational in my patient advocacy work as the primary care partner to 2 disabled adults and as I navigate my own journey as a patient. Looking forward to this conversation.
Thank you, Grace. John.
Sure. Well, good morning. I'm John White. I am the CEO of the American Medical Association for about the past 4 months. Prior to that, where I've met many of you over the years, I was the Chief Medical Officer at WebMD. I'm an internal medicine physician, and up until a few months ago, I actually worked at Kaiser Permanente. So it's great to see a bunch of the folks from Kaiser. You know, what I'm particularly interested in the conversations is how do we address clinical workflow? There's a lot of tools and ideas out there that don't work because they don't recognize how the workforce actually solves problems. And sometimes I think we're not starting with the problem and we're starting with a solution, and then we're surprised why they don't work. And I think an example of that is the issue of wearables, where there's continuous data over time, collecting in the home and elsewhere, which is really the future of healthcare. And we can argue that, oh, they're not medically grade, but this is iterative. They're going to get better. But if we don't have a way to get that data in terms of the workflow of clinicians, which is what we're seeing here, it's not going to gain the value of the technology. So that's what's top of mind to me.
Wonderful. Thank you. Micky.
Right. Hi, I'm Micky Tripathi. I'm the Chief AI Implementation Officer at Mayo Clinic. Really delighted to be here. Thanks for the opportunity to be here. Just prior to taking my role at Mayo, which I took in May of this year, I was the Assistant Secretary for Technology Policy, National Coordinator for Health IT, and Chief Health AI Officer at the U.S. Department of Health and Human Services. So top of mind for me is, and particularly in my role, is how do we strike the right balance between misuse, concerns about misuse of AI, and misuse and the opportunities that come from that. So we have a lot of focus on misuse, and certainly within Mayo and at the federal government level, we've had a lot of focus on what are the potentials for misuse, and it doesn't take much to sort of go down the possible parade of horribles, and many of them real. I don't want to dismiss that, but I think that we need to pay at least equal, if not more, attention to the misuse opportunities. Our healthcare system is not perfect by any stretch, and the opportunities for us to be able to use these technologies to rectify and indeed transform our healthcare system in ways that would be incredibly valuable for patients, I think is something that we really need to be paying a lot of attention to as we think about the enablement of these technologies. I think another concern related to that is, how do we make sure that these AI technologies aren't just paving over the cow paths, which I think Bakul was getting a little bit on part of the previous session that I heard. These kinds of technologies have the real potential to be transformative in many, many ways. And so we want to be able to say, how do we, not have those blinders on to the ways that we think about the existing healthcare system, and really think about, the transformative potential of these technologies.
So there are two pieces that I think are really interesting here that I want to hear people's thoughts on. One that we'll come back to later is this idea of innovating within existing workflows versus creating new pathways for care delivery and what that looks like. That's hard, but how do we do that? But the first thing I want to talk about is this concept you were talking about misused versus misuse. And I think it gets to this idea of innovation versus trust as well. How do we think through innovating quickly versus doing what we need to do to build trust so that AI tools can have as high impact as possible? So we'll go in reverse order now. If you could talk about what you think trust means from the different stakeholder perspectives that each of you carry, health system, and maybe, Micky, if you could put on your old FDA hat if you want to, a little bit of that from the regulatory perspective. From a physician perspective, from a patient perspective, what does trust mean, and what are examples of when trust and innovation can accelerate each other, or are they in conflict?
Sure. So, I think maybe starting with the most important first is that we absolutely have to have the trust of patients, and Grace will be able to speak much more eloquently than me on that. But that's the bedrock, right? If we don't have the trust of patients at the end of the day, then none of this makes sense, and none of this arguably is ethical, right? If patients don't trust what their providers are doing, that is highly unethical and not the way our medical system works. But from our perspective, then, that is, as it translates into a healthcare system, we work very, very hard to make sure that that trust that patients have in the Mayo Clinic, in our case, in everything that we do, in our processes, in our procedures, in our providers, in the entire healthcare system, that as we think about AI and the uses of AI, that builds on the trust that they already have placed in us. And we want to be able to have that kind of relationship with our patients, that the uses of technology that we believe are in their best interest and will allow us to provide higher quality, more valuable, more cost-effective care for them are something that they place their trust in our ability to be able to do that, as well as be able to share with them the benefits of that and the opportunities that are there for them. So, I think that there's a couple of dimensions to that. One is we want to be able to have more patient-facing technologies to allow them to be more directly involved in their care and have more agency, both themselves, to be able to say, from what we think of as pre-visit now to post-visit, which itself, I would argue, is kind of an archaic notion, right? I mean, if we start to think about this as more continuous sort of spectrum of people drop in and out of the sick care system, but they actually have a whole set of technologies now that allow them to really be doing much more on their own to the extent that they want to. We're working on the abilities to have more technologies that will be available to patients, working in concert with the providers at Mayo Clinic to give them greater agency, to give them better abilities to do things that they might want to be able to do on their own. And then being able to have those technologies that are incorporated in the patient journey that they have once they hit either the physical or the virtual door of Mayo Clinic, to be able to say, and there's a whole bunch of technologies that we're able to make available there that we want to make sure that that they understand, that they have trust in, and that are delivering valuable care to them. I think it's an interesting question of how much do you tell patients about AI technologies, not because we don't want them, we don't want transparency, but I think we're going to come to a point where these technologies are so embedded in almost everything we do that you get to a challenge of, well, how much can I say? How much can we say? Oh, that AI's in this, and it's in this, and it's in scheduling system, and it's in this, and it's in this. And so I think that that's something that we need to figure out. Obviously working on the basis of what are the kinds of things that we want to make sure that patients want to know, and then we're able to make that available to them. But also, how are we not overburdening them and hammering them with information that just may not be of interest to them, or may carry a whole other set of issues just related with they're already burdened with too many clipboards, right? The clipboard phenomenon. How do you not overburden them yet with another whole set of things that that may not be kind of relevant to their consideration? So those are all things that we have to work very hard with the patient community to better understand as we think about these technologies.
That's wonderful. Thank you. Sean,
Sure.
go ahead.
And maybe just to spruce it up a bit, I'd say, in listening to that, it almost sounds a very paternalistic approach. How much should we tell patients? I don't know how much they need to know. We should be very transparent with patients and give them all the information that they need, not what we feel they need to know. I think part of the challenge is we ourselves may not be able to adequately explain how these technologies work. I mean, if you asked me a year ago, how do physicians perceive AI, it'd be very different than it is today. And in our own surveys, we know that roughly 2/3 of physicians are encouraged by the use of AI. And that's significantly more than the previous year. Before it was really 50-50, as concerned as encouraged. Roughly 2/3 of physicians say they use AI. The reality is they're probably talking about things like AI scribe and some, back office expertise. That's not where we're going in an AI. But when you talk to physicians about what's going to get them to trust AI, part of it is the regulatory role. Many of them have talked about the role of the FDA approving a tool or clearing a tool. And then what I think has been very interesting that we don't always see, clinicians want to see that feedback loop. So if there's an error in these tools, how does that information get addressed? And how does that improve the process? I think as it comes to trust, a great example could be chatbots, right? In terms of how do patients know, first of all, it's kind of obvious sometimes we get confused whether it is a human or not.
Yeah.
That's the first thing, which would be kind of obvious, you'd think, but people do get confused by that. But how do they know that the information that they're being given, that they can trust? And that's where I think we're going to have a lot of discussion as these tools become more sophisticated.
I love this. Yes. And we'll go back to the patient perspective a little bit because, I want to understand what trust means for patients and also how we embed patients in the decision-making process of what AI tools we are using, how to use them. And this reminds me of a conversation, Grace, you and I have had where it's kind of incredible what patients are doing with their data right now. There are a number of folks. I have a colleague whose mom had a recent cancer diagnosis, and she is feeding her, her notes, her medical notes, and then she got up-to-date, information or guideline information into Notebook LM, and she's listening to a podcast about what's going on with her care, pausing it to ask questions, which she can do with this podcast, to get a better understanding of her health. And we know that that's so important because so many patients they leave doctor's appointments not really understanding what just happened. And how do we enable safe use like this and encourage our patients to use things that make sense while also supporting them in whatever their priorities are?
Oh, so many things to touch on here. I just wanted to recognize that Bakul did such an amazing job by sharing those two videos. And I really want the link to those because what it shows you is when we're all sitting here very casually, we're not in the emergency room, we don't have 60 seconds to make a decision. We didn't just learn that either ourselves or a loved one has a cancer diagnosis that's no longer responding to treatment or something life-altering, life-limiting. The world that I live in that's the world that I live in. The patients that I serve, that I have the privilege of serving, need access to not just information, tools, and technology, they need personalized intelligence so that they can make an actionable decision to operationalize. I want to give my patients a competitive opportunity and a competitive advantage against their diagnosis and against the friction and the fragmentation in our healthcare system. So when we think about trust, I look at just the examples this morning, the Bakul, that you shared in your video. A parent gets a earth-shattering diagnosis on their 7-month-old child. Would I love to spend the next 7 months with my doctor, one-on-one, partnering and working? Absolutely, but I don't have that. And many people don't have access to care. They may not have a trusted relationship with a physician. So now we can upskill and start working somewhere. Can we do a better job? Absolutely. With the diagnosis should come maybe a simple sheet of responsible prompts, and here's some peer health support, and here's a community health worker that can help support you. We need a point person inside our healthcare system where a patient and a family can go to learn and explore with curiosity about AI. And Micky, going back to some of your comments on what patients need to know, here's where we completely dropped the ball. We've been using AI successfully in our infrastructure and workflows for well over a decade. We don't talk about it at all. That this has transformed scheduling, that this transforms how we route patients from the emergency room to make sure that there's a bed, how we triage and make sure that this radiology is exactly this diagnosis. We don't celebrate the good that's already been happening. So what's happened is journalists have gotten hold of all these things, and now there's fear-mongering. And now, when a patient comes into the exam room, we have so many successes. Daniel and I recently were on a panel, and he shared his 6-month success with what's been happening with ambient listening technology. And when I go into an exam room with patients, I'm seeing consent being asked for, the technology being explained. And before we hit record, my patient and my family say, oh, but I want to use my tool and technology to record too. And it's an immediate friction point. We don't do it that way. You can't use that. That's not HIPAA compliant, and an immediate friction point. So I'm seeing this break off in trust as I'm talking about trust. There's this expectation that patients need to trust their doctor, their healthcare system, their providers, their payers, their community health system. But we don't get that trust to use the tools ourselves, and the majority of the care is happening in our home. And when I think about how responsible adoption, implementation, deployment, we need to bring community voices. We need to bring diverse perspectives, because I can assure you, like any bell curve, there are advanced users. There are people that are teaching and coaching their communities, their families, their patients, who we could all learn from. So please, let's include the patient and care partner perspective in all of this and co-create and solve this, because no one knows it all.
So fantastic. Let's stick on this point for a little bit, on having patients at the center of the development, the use, the design process. And I'm curious to, maybe we can share kind of in our own institutions how we've tried to do this, and we can kind of work together to figure out how we can do this better. I know at least at Stanford, part of what we do for AI tools that we deploy in the healthcare system is every single one of those tools, we have a discussion during our ethics evaluation with patients and with families. And there is a patient and family group that we bring their perspective into how things should be deployed. And one thing that's fascinating is you see that there are so many different priorities. Let's take a very simple AI algorithm, maybe some sort of deep learning model that identifies patients at high risk for a certain disease. I'm a cardiologist, so we'll say structural heart disease. The physicians are thinking about capacity concerns, making sure that they get the people who they can do the most medically. But patients often are saying, hey, if I have any kind of problem, I want to know about it so that I can take preventive steps. I can see if there's prevention out there. And so the threshold in which notification based on an AI tool should happen is even different between patients and providers. So I'm curious, that's just one example, but let's maybe go through and talk about how we've incorporated patients and how we can do a better job incorporating patients in decision-making around AI.
I think we have a lot of work to do in how we incorporate. And I actually love the example that you shared, how Stanford is engaging through patient family advisory councils. That's a starting point, but that's not the solution. We need a budget line item here to support and compensate the leadership and expertise, the time. If we don't do that, then only those that can show up to a patient family advisory council, those that have transportation, those that have paid time off, will dedicate the time. And these are longitudinal efforts. This is not, okay, let's meet for a focus group. Here's a bagel and a coffee. Thank you so much. I love the the feedback of providing value in the last conversation. So we're inviting, in some cases, patients and communities to share their thoughts, but we're not saying what difference it made. That's not engagement, that's extraction. There's a difference. Sharing that feedback loop is incredibly important for building trust, and then having that open dialogue of constantly having this flow of knowledge exchange. A lot of work left to do, but I do feel I'm going to encourage everyone, if you haven't already, follow the Light Collective, take a look at the AI Rights for Patients, because that was done in partnership with diverse representation of patient voices. And there's 7 pillars there that really outline what patients want and need with respect to AI in healthcare. There's a survey there that was done by the Light Collective that said the majority of patients do want to know, over 90% want to know where AI is used in their healthcare. And I know, Micky, you and I have had this conversation about, well, now if an output is generated from an AI-powered tool or technology, and if that output is used to make an informed decision about an individual's care or coordination of care, doesn't that fall under the designated record set? And shouldn't a patient have access to that output? And where it matters, so use cases are great for healthcare. We always talk about use cases. My patients that need to go to tumor board, my patients who no longer have exhausted all standard of care, that output could help maybe get them into a clinical trial. Having all of that information could help power research for rare disease. We just don't have access to those outputs, and I understand that there's no standards or structured form and format really for the exchange and flow of that information yet. So I think as we're going to build trust, the more these tools are deployed, yes, I as a patient would love to have that information in my medical record so that I can take it and use it as I wish, and also share it with my care team in confidence.
Amazing. Micky?
I'm just going back, I was thinking about John's comment and Grace's following comments. And, I wasn't suggesting that we deny information to patients. Mayo Clinic's motto and vision and core mission statement is the patient always comes first. I was talking more about the practical reality of, as these solutions start to become more and more prevalent, it start to face just the practical reality of what is it. So, we use a bridge and we use ambience and we use a couple of other solutions across the practice. Every single time the patient is asked for consent to use those tools, right? So anything like that, absolutely, you're getting consent. But let me give you a couple of other examples. We use open evidence, as many provider organizations do. We've used UpToDate for years. We never asked a patient's permission to use UpToDate. Now we're using open evidence. I will almost guarantee you that provider organizations do not ask the patient's consent for whether they can use open evidence, right? Based on generative AI. So we also have a set of ECG dashboards, for example. Sneha, you're a cardiologist, that have been developed that take a simple ECG signal and break it out into multiple different views from that signal using AI technology. And that allows the cardiologist to actually order that as a part of a cardiology visit and have different perspectives on a patient's risk and indeed give them a physiological age that they can compare to their chronological age, and then help to talk with the patient about, what will help here? Exercise will help. This will help. This will help to be able to bring your physiological age down because you have these risk factors based on the AI technology. Now, as that gets more and more baked into just the ways that they're doing it, they order that just like they do other things. I'm just pointing out the practical reality of, how do you actually, have a patient consent or have that individual transparency for every AI-enabled technology you're using. So I think that's a little bit of the, sort of the back and forth. The last example that I'll give is always keeping in mind what's the benchmark against what's happening today. So we have another technology that we are now piloting, and other healthcare organizations across the country have a similar type of technology that a radiologist in a typical hospital setting, for example, or a big academic medical center setting, for example, like Mayo, will come in the morning. I talked to a radiologist just earlier this week who said, I got in at 4:30 a.m. because I had to review 125 chest x-rays today. Think about that, 125 chest x-rays they're going through. Now, we have a tool that we're now piloting, that we've co-developed with Microsoft, and we're doing a bunch of work on that will save them 30 to 45 seconds per chest x-ray. Early indications. Obviously, it has to be proven. We have to do a lot more work on it, but the early indications from the early studies are that it'll save 30 to 45 seconds per x-ray with at least the same quality to generate a first draft radiology report for them, that then they're still responsible for the report, right? At the end of the day, the radiologist is responsible for reading that report, signing off on it, but it saves them 30 to 45 seconds with some confidence that it is at least as high quality as, as most of the human readers who are a part of that. That's a tremendous benefit if you think about the benefit to the patient and the benefit to the provider, and you think about how many more of those technologies we're going to have. And then again, the practical reality of how much can you actually convey in a way that's going to be meaningful to patients. We did with Health Information Exchange, we always ran across this, Grace is very familiar with this, that sometimes we say consent, 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 but then we hide behind it because you end up giving fine print of 3 pages that the patient actually doesn't even read, and that actually isn't meaningful, participation or meaningful understanding of what's going on. So I think that's a little bit of the balance here, and I'd strike that same analogy to what's been done with data exchange to say, how do we think about meaningful consent and meaningful transparency, and not just, superficial transparency around things that, end up being not accomplishing what it is that I think all of us want to be able to accomplish.
I want to also add, I think there's 2 issues as it comes to trust. And one is around, I think there are some generational issues as well, in terms of I find younger patients are much more interested in sharing data and using tools, and older patients, stereotyping a little bit, are more kind of, what do you think, doctor, and advice. But something I'd reflect on just hearing the other panelists is there seems to be very much a focus on either inpatient care or higher level care that we're talking about. And one could make the argument that the real value of innovation is in an outpatient setting and outside the hospital walls. So even as you talk about cardiology, I could say maybe the real value is HRV, heart rate variability, and how do I use innovation to measure that? I mean, I've talked before about where are we on blood pressure? People want to talk about the number of steps. If we could continuously measure blood pressure in an outpatient setting in a meaningful way, we could reduce cardiovascular risk dramatically. So we're not at the point when a patient comes in and we have to think about structural heart disease and other issues. And there are many incentives as to why we focus on inpatient settings, but the real value is before they get diagnosed with cancer. How do we use innovation and AI tools to do that? And that's not where we're seeing enough the innovation that we need.
I'm really glad that you brought that up, because I think that it becomes about more than just the technology, right? It's not just that the AI tool can give us information. How do we act on that information to create patient benefit? Grace, I saw that you wanted to add on to this a little bit.
I love the emphasis on before they're diagnosed, but the majority of my patients are diagnosed and they cannot get the care. Just this morning, I had a patient say, triple negative breast cancer. I can't get anyone to call me back. I just want this MRI rescheduled. No one's answering my portal message. I've left a dozen messages. I'm faxing. I'm taking the day off and I'm going there. And I said, I don't know if that's a good idea, because likely that office is not scheduling it. So we're losing patients in this process. And then there's an opportunity, I think, across the entire patient journey in the outpatient setting to benefit. And how do we use that? I think we're stuck in, I love there was a conversation about metrics and how we measure. We're completely missing the mark on metrics that we should be capturing, because we can use the outpatient setting to boost that is engagement. This is patient engagement. All this chat GPTing and the portal messages that we're seeing, that is patient engagement. We don't count it as that. We're able to capture and bring patients in if they get credible information that would say, here's where you need to go next. Most patients just want to know what their next step is. Help me untangle this mess. I don't know where to go. Who do I talk to? My primary care doctor can't see me for 6 months. That's just not going to work. Something else that we're not talking about, everything is very AI focused. But thanks to the efforts of the national coordinator, Micky, and many of his other colleagues, we have access to our medical records, more information than ever before. And people are using that. And I think post-pandemic, where we all were left to try to figure out how to connect to care, how to connect to COVID tests, how to connect to routine care outside of COVID, the population is just savvier. Now we have technology, tools, and information, and we want to be able to use that. But when patients use it, we discredit them and say, oh, you're not ready to do that. This isn't ready for deployment. It's going to hallucinate. I just want to share, it was also mentioned before that doctors also make mistakes. I'm a cancer misdiagnosis patient. I was diagnosed with advanced lymphoma. I took my medical records and went to a second opinion at slow months of biopsies that were inconclusive, very invasive, numerous tests, endless imaging, constant blood work, video-assisted thoracic surgery, and waking up after surgery being placed in isolation, finally being told it wasn't cancer, but they didn't know what I have for another 3 days, but they thought it was tuberculosis. And the ultimate diagnosis was histoplasmosis, a fungal infection that I got on my honeymoon practically 2 years prior that needs no treatment but just monitoring. That was my wild 4-month ride. Had I had an AI tool that would read my radiology and said maybe, hey, this is an advanced lymphoma and we don't need to treat this, I would have loved that. So I think there's an opportunity now. We're trying to drive change from top down, but I think let patients and communities help bottom up.
And this gets to a concept that was described before about, we shouldn't compare AI augmented care to the best possible care that anyone could ever receive. We should be comparing it to the real care that patients are getting every day. And so to tie this back to trust, when we think about how we evaluate these tools or monitor them over time, which is probably more important, monitoring over time, what's the benchmark? What's the thing to compare to? And does that differ depending on the setting in which a patient is receiving care or a clinician is practicing? Anyone who wants to.
Yeah, and I think, again, we'll see what happens in the federal regulatory front, because that sets a little bit, I don't even want to call it a floor, because there are some things that the regulatory approval, I think that people think that an FDA regulatory approval does more than it actually does. So let me just say that.
Can you go into that a little bit? Because I think that's really important for this.
Yeah, I think that there is a sense that, this has gone through all sorts of validation from a performance perspective, from a safety perspective. The vast majority of AI-enabled technologies go through the 510K pathway, which is basically attaching it to something else, which means that you don't have to submit a whole bunch of pre-market stuff. You don't have to do pre-market validation. You can basically say, oh, my AI technology is kind of like that thing that you approved 5 years ago that wasn't really an AI technology.
But it can also be software as a medical device, which is a whole other
Well, I'm talking about software as a medical device. This is all software as a medical device.
But many of them will want not to be a device. That's part of the challenge.
Well, but I'm talking about the realm of software as a medical device and the pathway that most AI technologies have gotten approved by the FDA go through that process. And I'm not criticizing the process. I'm just pointing out that that they don't go through the kinds of rigor that you would think that for like a PMA, right? The highest risk kinds of things, like an MRI, for example, goes through all sorts of, very rigorous, kinds of processes for validation in patients.
And Micky, is it right? It's over 95% go through the 510K pathway.
Yes.
Well, that's devices in general. That's not just AI tools.
No, it's devices in general. It's if you look at the 1,000 that have been approved by the FDA, it's about 95% of them went through the 510K pathway. That's exactly what I'm talking about.
But it's the same for devices in general versus AI. The only reason why I say that is we're not holding them to different standards.
But I'm not talking about a different standard. I'm just saying that people think that the FDA approval does more than it does for the AI solutions that we're talking about here. But I think that we also do need to balance this question of, and I think Grace was getting a little bit at this, is we've got the rocket science, and certainly Mayo Clinic has got a ton of rocket science going on. We have like 350 to 375 internally developed solutions that are in the pipeline right now. That doesn't include what comes through Epic, doesn't include a bridge, Ambience. These are internally developed solutions that are making their way up. So so that's why, we've got the practical reality of, well, how much can we say about every single technology that's coming through? Because there are literally hundreds in the pipeline. But I would also point out that we do need to balance this question of AI technologies can give access where there isn't access. So the idea of comparing it to the current, within Mayo, we'll compare it to, well, how does the human practice work today? Like I was describing the x-rays, for example, and say, well, geez, if this is equally high quality, but it saves time, then you've done a lot. For the patient, you've done a lot for the provider organization. But something like 80, I forget the exact data, but I don't think I'm far off, something like 75 to 80% of counties in the US don't have a cardiologist within like 100 miles, right? And you just think about that for a second and think, what would the patient want if you told them, you know what, we created this technology that that is a virtual app that can do some cardiology screening for you. It's been through this kind of rigor, and it's 75% accurate, whatever it is. In a medical setting, that might be like, not good enough, sorry. If you ask the vast majority of patients, they would say, absolutely, please give it to me.
Yeah.
Because I can't even get to a cardiologist. And that's not even counting places that don't have access to primary care in the US, let alone in other countries.
And
I think that's a little bit of the balance that we need to think about.
Yeah, and we heard a little bit about this earlier today about how the regulatory kind of appetite is different globally depending on what you're comparing to, which I think is really valuable. I actually want to take this moment because we have about 11 minutes left till we go to the audience for questions. I want to think a little bit also about the clinician, and I want to ground it in an example. So at Stanford, we've deployed something called Chat EHR, and this is a chat system within the electronic health record that pulls data from the patient's chart itself, and the physician can chat with it. So I'll give you an example. In my day-to-day practice, when I see someone in an outpatient setting, I want to know what's happened to them in the past 6 months since I see them. Usually that means clicking through about 30 to 40 clicks into all the other subspecialists that they're seeing, looking at their records, looking at their what Care Everywhere data. We use Epic, and Care Everywhere is looking at other health systems. With Chat EHR, it pulls all of that information so I can ask one question to summarize what's happened to the patient in the past 6 months and get a really nice summary about what has happened. Now, can hallucination happen? Absolutely. And this brings me to my question, which is, right now, the liability and the responsibility of checking the generative AI tool remains with the physician. And in some sense, this makes sense, right? The physician is the one providing care. They are the licensed one. It is their responsibility to make sure that information they provide is accurate. But when we make the argument that these tools are supposed to be making physicians faster, maybe one day require them to see more patients to solve some of the access issue, I think we have a responsibility on the trust standpoint to also accelerate the ways that physicians can do quality control. And I'll give one example where we're doing this is citations. So when you get some sort of generative AI output, you can hover over the screen so you know where it came from in the chart. So the physician doesn't have to go through and click those 40 clicks I was talking about just to check. And so I feel like there's not enough being talked about when we think about efficiency of AI tools with the work that is combined there that clinicians need to do and compensating for that work and not just expecting them to be faster. John, I'm looking at you because I want you to talk about this.
And I would, and I'm trying not to be the argumentative one on the panel, but I would take issue with your definition of efficiency. I think your definition of efficiency is from a health system perspective of the doctor should see more patients. And I think if you ask most doctors, no doctor will say, I want to see more patients during the day. I want to spend more time with my patients. Yes. I want to have a more comprehensive assessment. So that's what that tool should be used for. So I can do more during this exam and actually have a more comprehensive follow-up plan and not to now see more patients. And I see that with a lot of tools, how they advertise and market. That's how they define efficiency. And efficiency is more about getting a better outcome, not necessarily based on time with fewer resources.
But I have a question for you here, because as a physician, I totally agree with you. Most of these AI tools, when they're selling to healthcare systems, they're selling to the CFO.
Oh, absolutely.
They're not selling to the physician. Yeah. So how do we think about capturing maybe that value that you are outlining and helping that bring that into the decision making about what tools should be deployed and how they should be deployed? And maybe, Micky, I can go to you as someone who's at the health system level, also at the regulator level previously. How do you think about that? Capturing value of AI tools that is not just financial and time efficiency.
Well, for a lot of these, I guess I would argue that there isn't, an ROI in the sense that a CFO, a hard-boiled CFO would recognize, just because of the convoluted economics of healthcare, right? It's very hard to, sort of say, here's my return, it's going to, be this X many dollars. A lot of the things that we do, to your point, are in, time savings. I think it's a very fair point that John raises, and it's a workforce issue that, that I think for a lot of the workforce, certainly our healthcare professionals, nurses, physicians, sometimes that is said, and what they hear is, great, I'm going to get 2 more patients piled on me. I think that's absolutely true. That's not good for the patients. That's not good for the providers. So, we try to work really hard to say that is, about being able to, certainly in places like Rochester, and you have limits on how many people you can hire. And so there's, that ends up becoming a hard constraint. So you want to be able to say, this is making it easier for you to do an already difficult job with these kinds of tools and, being able to do that. But I think that there's always, sort of a back and forth there.
Yeah.
I think one of the challenges of, of trying to, sort of build trust in the validation of these systems and, and these kinds of things is like, again, you get to some of the practical realities of this. You have, well, I'll give 2 examples. One is for like a radiology type of system, you want to do what's called a reader study, right? Which is against, it's comparing it to current practice. So you basically say, well, I've got this AI tool, and we're going to get 12, I'm making this up, 12 hours, 20 hours of radiologist time where they manually review, go through the existing process they have, and then we compare it to the AI, right? And you think, okay, I'll get 10 radiologists, they'll do 2 hours each. The elapsed time of getting 10 radiologists to give 2 hours each for the ones who are seeing 150 a day, literally, it'll be like 10 months later, we're still waiting for the reader studies because the doctors are so busy, right? So that's like the practical reality of, man, how do you get these things out when, when everyone is too busy to think about the things that might give them greater efficiency, right? That's, the classic dilemma. The other thing is there's a lot of nuance, I think, in how you think about mitigation of some of these, the potential risk issues, like the summarization tool, for example. We have, I'll put side by side 2 summarization tools. We have a summarization tool similar to your EHR chat that we developed within Mayo that summarizes, the Epic record, outside records, not only just care everywhere, but even outside records that come in as scanned documents, other kinds of things, versus the radiology one that I was describing before. The clinician is responsible on both of those things. I would argue that we want to actually do more diligence on the validation of the general summarization tool because the human oversight there isn't quite as intensive or specific as it is for the radiology tool. And the reason I say that is that a radiologist, they know they are responsible for the radiology report. So they get the summary from that and they are signing off on it, right? Because that's what they do. They go through every single line and they sign off on it because that's what a radiology report is. A general summarization tool, you actually don't know if it missed a whole bunch of data, right? And we've actually, unfortunately, had the experience where this summarization tool, based on a large language model, was missing certain records, but there's no one there who is actually looking to say, wait a minute, is this missing something? Whereas a radiologist would be doing that, right? Yes. So you think about the different kinds of risks. You might think in your head that, oh, the radiology one is clearly higher risk. I would argue, well, with the human intervention, the human oversight there, actually there's a mitigating factor over here which gives us more comfort with this tool than with the general summary one where we're going to say, you know what, you have to meet a higher bar to be able to just say we're going to make this available to everyone because the automation bias problem with that is the provider will think, oh, I've got all the records. When, there's no indication to them that they don't have all the records.
So this is really interesting because it's getting to different types of evaluation for different tools. And then I want to ask...
mitigations.
And different mitigations, yes, and different mitigations for different tools. What about what information needs to go to the patient, to the physician, based on these different types of tools? Is it, for a long time, there was all this focus on model cards. Is that, something that's actually going to be helpful for agentic AI tools or generative AI tools? What about the monitoring piece? How often do you need to tell physicians and patients about how well things are working? Thoughts, Grace?
I'm going to back it up even further. So when patients are looking to select their care, Micky, you mentioned that Mayo has 375 in their pipeline. Gosh, I would love to know that. Because patients are looking, so we're looking at the lens of being financially responsible and the lens of financial toxicity, which is a known side effect of cancer care. So when a patient goes from their local community center to go to a center of excellence, that's a big decision. It's a bigger decision if they have to go to a trial or they have to travel somewhere thousands of miles away. We don't know what anyone has in their pipeline because we can see the bios of all their physicians. There's no catalog online that says, okay, MD Anderson is using this to read radiology and Mayo is using this and Stanford is using this. Those things matter. Am I getting duplicate care? If I went to MD Anderson, now I need to go for a third opinion. Do I go to Stanford or do I go to Mayo? But what if you're using the same thing? So I need to, well, no comment. And there's costs incurred across all of these. So, when you look at it, I was sitting in an Uber and the Uber driver said, well, I have lung cancer, but I'm not going to get care. I'm just going to drive my Uber as long as I can because I don't want to bankrupt my children. So it's not a matter of connecting to care, going to the ER. It's a matter of connecting to care. Do I pull my whole family under for the next generation? So we're also not looking at the way that people make decisions and communities make decisions about how they pursue care. And I think AI has a lot of potential to help with that. Yep. But again, doing some basics, yes, model cards are great, but we have a lot more work in background because people are engaged and need to connect to care that's important, and then they want to invest their even limited resources if they have that information that it's going to help me, it's going to help abuela, it's going to help my child.
So it sounds like it's not about, tell me if I'm summarizing this correctly or totally off. It's not about just the one-off AI tool, but the entirety of the care and what they will receive and having some way to kind of evaluate that.
Absolutely.
Okay.
But I think that then comes to your point that you've described over the last hour, that at the end of the day, patients want someone that understands them, that gives empathy. And that's why they're calling you and trusting you, because you understand their journey and you're telling them how you're going to help them get better. And I think that's an important element. And we used to see that years ago, which I think is different, where if you told someone that they had diabetes, right, and you say things during the clinical exam, they're barely going to listen to any of it. And what they're going to do, in the past, they would go home and they'd Google, because that's all they have, and they'd read a whole bunch of information. And then what's the next thing they typically would do? They'd say, oh, you know, your cousin has diabetes, or this friend of yours has diabetes, and they call someone who's going to help explain it to them at a different level that they trust. So I think that's the challenge as well, because when you put it into that comprehensive package, right, all the tools that they could use, and we could have all that transparency, but at the end, they want advice and who they can trust. And it's still very much their doctor that at least they want to trust in terms of the decision making. And that's what I think complicates matters.
Can I add?
Yeah, of course.
Yeah. Let's say that your health system had every tool that you had, and now you have ratings that patients use this, or doctors and patients had success with this specific tool. There's no feedback on which tools are effective. Even if I look at the website on the FDA, all of the different tools that are approved, I have no idea what's actually working in which community and which location at which health system. So there's this feedback. I love that keeping that AI in the loop and using humans example. We need to put more humans back into this, because we're sort of lost in this wave of AI, and how can we have people, the physicians, the clinicians, the end users, putting more feedback into the system to inform how we use AI.
And I think that's interesting, because there is a lot of informal peer-to-peer learning happening. When a health system starts using a tool, they have a good, like, there's so many phone calls that I'm sure everyone on this panel has been on, like, oh, this tool has been really helpful. It's not the traditional clinical trials and best, tool that has emerged. Now everyone is going to use that. And we need something better than this informal access to information that only some people have access to. So I think last question, then I would like people to start raising their hands for questions, and we can start, going around, is what is the level of evidence for maybe higher risk tools? Let's just focus on higher risk tools. Is it more observational causal data like the health economists do? Is it more formalized peer-to-peer feedback? What does everyone think? Micky, let's start with you.
Yeah, I think it varies a lot. I mean, one of the things that is kind of the operational reality as we're seeing, because we have so many internally developed tools that we do have to sort of be very thoughtful and very proactive in how we think about that. Where you may have other systems that most of their AI, I mean, every system is going to be having AI, but in some places it may be that most of the AI is coming through vended solutions. You have a different problem there, but a lot of it is, you're not the manufacturer, you can contract for a certain set of things, and you're not in the guts of it, so you don't have the primary responsibility for evaluating it before you actually deploy it. And you have a certain degree of comfort that it is a vended solution. Whereas the internally developed ones, we have the responsibility, and we have to think about it, from soup to nuts. So there isn't a single way. I think that's one of the challenges, right? That with some type of tools, there is a quantitative set of metrics that you can do. You've got an AUC, and that is meaningful in certain ways, and 0.93 versus 0.82 is actually meaningful. But there are other kinds of things that don't lend themselves to that kind of evaluation, and you're doing more of a rigorous, more qualitative kind of assessment to assess what's the value to it. And then this balancing of risks again. Just that example I gave before of the summarization tools. It's not obvious what's the right, sort of balancing of risks. And, from our perspective, we want to be thinking more about how do you think of risk in a holistic manner? So that you have the opportunity to say, well, it's not just about everything that I'm able to do, pre-deployment, because there may be a set of things that I say, you know what, we can manage the risks once it's deployed through post-deployment monitoring of the systems and very heavy human oversight, like the radiology thing that I was talking about, that would give us greater comfort of putting something that might be seen as a high complexity thing into the field so that we're able to do that, but we're able to closely monitor it while it's deployed. Whereas another thing, you may say, well, I actually don't have a good enough set of controls on the post-deployment because I can't do the monitoring as nearly as well as I'd like to, or the human oversight doesn't really look like it's nearly as intensive as I'd want. So I'm going to put more on the pre-market side to say, no, you need to do more upfront validation, kind of testing. So it really is very heterogeneous in our experience.
Oh, thank you. I want to make sure we have time for audience questions. So, and I think I just want to say that it's great that we have some discussion and disagreement up here because it shows that many of these questions are not solved questions. And
John's the only one disagreeing.
Yeah. John, okay. Only John. Go ahead, please.
I made the comment before that I think we're still in sort of the dial-up phase of AI in healthcare. As panelists, you all get one wish. What is your wish to move us more towards the 5G broadband phase of AI in healthcare? Just one thing each.
Grace, let's start with you.
Come on. I'm thinking top of mind, the National Suicide Hotline. We just had this conversation that when a patient has suicidal ideation, they can call a standardized number and there is a national level of support. I would love to see, let's start with the use case. I'm going to be biased because I work in oncology and that's my love. A national hotline where someone can't get the care they need, a diagnosis that they're uncertain, not responding to standard of care, need a trial, right to try. They call a number with their challenge and they're connected. And it's not necessarily just to AI, but AI could power this, but we also need humans there to help. That would be sort of my wish right now. Connect so every patient has access to almost an advocate at the speed of dialing a few numbers.
Amazing, John.
Similar to that, I'd say there has to be equal access to innovation, and I think rural hospitals are particularly at risk of missing out on some of the innovations that are being developed. Grace and I were chatting beforehand. I think when we think about equal access, it's as simple as that everyone with a cancer diagnosis should have a second opinion driven by AI, that cancer care is not routinized, that community oncologists are dealing with a variety of cancers. There's no way they can stay abreast as best as they can on all these areas. So how are we developing a system that provides that equal access?
Yeah, I guess for me, and this may seem odd, but it's moving very, very aggressively toward value-based care, because I think we're just about to come at the point where these systems start to look unaffordable, or we start to see, of the 1,000 solutions that have been approved by the FDA, something like 98% of them actually don't have a market. They literally aren't sold. Now, you could argue maybe the FDA process, squeezes all the creativity out of them. That would be one argument to make. But the other is that the economics of our fee-for-service system don't really, sort of have a way of compensating people for taking these technologies and saying, you know what, I think this is really high value and it's going to pay off for patients and we want to put it out in the field. So I think that we need to be much more aggressive in that. And one of the things that we're finding is that there's a lot of attention paid to the development cost of these things, but it's actually the ongoing costs that is way more than we thought. The compute and storage costs for what are even seemingly simple solutions, and our Google Cloud bill is unbelievable. But the ongoing costs of these are way more than people think, and so I think that's going to be a coming challenge as people start to say these are great ideas, but our fee-for-service system doesn't support it.
And my wish is to erase the line between healthcare or health and evaluation and research, if you will, to try to think about how in the delivery of care or in the delivery of health outside of the healthcare system, how we use those ongoing daily operations to generate the evidence to build the trust and the innovation we need, instead of saying, we need a clinical trial for this. We need some separate artificial evaluation. We need X, Y, Z. How do we bring those two together? Any other questions here? Daniel.
Hi, terrific panel. You know, Micky and John, both of you have undergone recent career changes. You know, Micky, you went from regulator to regulated. And John, you've gone from what was in many ways a consumer-facing platform to now really a physician-facing platform. And so the question is, what has surprised you as you've made these transitions? What are some things that you might have shared with your prior self a year ago, things that you've learned, insights, perspectives that you've gained in these new roles?
Want me to go first? Sure. So, yeah, I guess I would point to two things. Well, one, I have had the unique experience of having been the regulator and then going to that side and looking at the regulation and being like, who makes this stuff up? Like, unbelievable. I'm only kidding. No, I think the thing that has surprised me the most, and I don't think it's just because I'm at Mayo Clinic, is how fast this innovation is happening. I didn't expect to come into an organization where we had 375 solutions in the pipeline, up to a third of them now, generative AI, and we're building our own multimodal foundation models. These aren't vended systems. We, within Mayo, we have a Blackwell cluster. We're building our own multimodal foundation models. I didn't expect, I mean, if you had asked me in January when I was leaving, how far off are we, you know, and Stanford's doing the same thing, you know, the organization's doing the same thing. If you had asked me how far off are we from that, I would have said 3 years, maybe 4 years. And, you know, and then I enter Mayo in May, and it's like, oh, we got 10 of these going on and 350 solutions, and your job is to figure out how to get them into the bedside safely and effectively and as quickly as possible.
What I would say, Daniel, is I think there's actually a lot of synergies because it's all a continuum, whereas I think both for physicians and the public, they're interested in the user experience of these technologies and tools, maybe from a little bit of a different usage perspective, but the usability is very important. I think the issue of trust is important, that patients want to know, can they trust this information that they're getting online, say when I was at WebMD, and doctors want to know that, you know, if they're using open evidence or other tools, that is this being summarized well, and can I trust it? And then the validation of it. How do I know that this is the most up-to-date? So it's actually remarkably very similar in terms of the categories that folks are interested in, whether they're a patient or a physician.
Thank you. Other questions? Yes.
Hi, good. Sonia Allen Smith. I have a question. First of all, I really want to say that it is very refreshing and it scratches my soul to hear the advocacy around educating the community and the members about the importance of AI. Thanks for the advocacy on it, because the patients do want to be engaged in their health care. But I also have this question as a worker within Kaiser, rank and file worker, is to ask, how are we educating the frontline workers that are working with the patients that AI is, one, not there to take their jobs, but there to help the expedience of healthcare, just as we displayed here. Because when we talk about trust, the first person that a patient comes in contact with is a receptionist or a allied healthcare worker. But what is the conversation happening on that front end to help encourage the utilization or the involvement of AI with our workforce in healthcare?
John, Micky, do you want to take that on the health system side?
Yeah, I'm happy to start. So I think, thank you for the question. It's a great question. It's an ongoing conversation, I think, because I think people have genuine fears and you know, and understandable and valid fears. I think, you know, certainly within healthcare, I think there is the reality that, you know, that our problems in lots of places are that we can't hire enough staff, that we can't find them. And so the ability to be able to alleviate some of the, you know, the kind of rote work that burdens nurses, frontline, healthcare professionals in general and the administrative staff all are, sort of burdened by all this rote work. And if we're able to alleviate them of that and then, give them the opportunity to do more, I think that that's, something, an ongoing conversation. And obviously that, the proof is in the pudding. I mean, I think that what we've been doing, we've been trying very hard to reinforce that messaging. And then when we do it, we actually show them that, look, this didn't lead to, huge reductions in force. This actually did lead to your being able to spend more time on the things that, that you as a human are, best able to do, and taking more and more of this routinized stuff off of your plate. The other thing that, that may be a little bit unique to Mayo is that, as I described before, we have all of these solutions that are, really organic. We don't dictate where people can innovate. And so one example I'll give is we just are rolling out a solution that we call the nursing virtual assistant, which was developed by the nursing department. So it's nurses themselves who are developing solutions. And now we have, before the end of the year, we'll have 9,000 users, nursing users, who are on this medical summarization tool that's specific to the nursing experience. And so there's no substitute for solutions that the people who are doing this day to day come up with a solution themselves and saying, here's a problem that I want to solve, and then, then being able to use it. So I think we're having, again, that'll vary a lot by department and, what we're talking about, but I think that's another part of being able to engage them directly and how these technologies can be useful to them.
And I really think that that's worth highlighting, underscoring, is involving the end user in the design, deployment, and monitoring process. And this is true not only for our healthcare systems, but also, and I'm sure that some of our, colleagues here who are from Google, Bakul, and others are using that end user feedback throughout the process, so we're actually solving problems that are worth solving. So I really like that. John, is there anything you wanted to add on this question?
No, I'd very much agree with that. I think for the most part, no one thinks that AI is going to replace clinicians, whether it's doctors, nurses, or pharmacists, or either frontline workers. I think it's really about reducing some of that administrative burden, the other tasks, so they can perform really at the top of their game in other areas.
Mm-hmm. We have a long way to go to improve healthcare generally.
Supposed to be the end of radiologists, and we can't hire enough radiologists still to this day.
I think the bigger issue there, to your point, although a lot of it is about frontline workers, is how do we use innovation to address the workforce? There are not enough physicians. There are not enough nurses. There are not enough pharmacists. Yep. That's not going to get any better in the short term. So what is the role of chatbots? What is the role of innovations, these other tools? That's really the next discussion that we need to be having.
And I think a lot of health systems are investing in upskilling their workers so that they can best use AI tools to do their jobs well and to solve some of these bottlenecks and capacity constraints you all are talking about. Great. Other questions? Okay.
Hi, Caroline Lucas. Wondering about the use of AI as you routinize some of the more mundane tasks. You're really asking physicians and other providers to operate top of scope at the very most complex level of decision making at all times without kind of that rest that some of the mundane tasks do allow for. How do you prevent the brain strain that happens when you're continually asking folks to focus at top of scope all the time?
Mm-hmm. John?
Sure. I mean, as you know, we're very focused on people practicing what their license allows them to do. And there's issues of scope creep where we have some concerns as the American Medical Association about people practicing beyond the scope of their license. But I think you raise a very good point. It's about how do we manage complex cases better, to your point, in terms of misdiagnosis. And that's a challenge, that no one wants to have that high level acuity every single day. I think this goes back to what I talked about at the beginning. It's about understanding workflow and how do you help manage workflow. And those are the problems that we should be solving and starting with that. How do you manage it that way rather than saying, oh, here we have a tool to make you more efficient, to see more patients during the day. So it's a great question, which brings in the issue of letting people practice at the top of their license, but not beyond that. And then how do we have these other tools recognizing there are shortages? And that's why, even in my clinical time here at Kaiser, just the level of acuity in primary care is greater than it was just a few years ago. And that's where we see a lot of burnout.
And I think, John, to go back to something you had said before, I think these AI tools, yes, it will allow people to operate at the top of their license, but also do the things that are uniquely wanted that our patients uniquely want humans to do. And that's not necessarily the most burdensome, high cognitive load tasks. And John mentioned this earlier, right? More time to spend explaining, talking face-to-face with your patients instead of being locked behind a computer. And that actually, I think, will invigorate providers rather than cause more brain strain, because that's, if you ask most of us physicians why we went into medicine, it was not to do a bunch of administrative work, and it was not to do a lot of the kind of mundane work that we hope AI will take over.
I'd like to share board-certified patient advocates. I think just as an example, being able to access medical records, where normally I would spend, let's say, 40 to 60 hours trying to aggregate medical records for a new patient that I may be supporting. That goes so much quicker now because everything's available in a portal. I would much rather be spending 40 to 60 hours supporting a patient in the nuance and the art of medicine and the decision-making that they need to do, as opposed to filling out clipboards, going to medical record departments, collecting, images on CD. So I think removing that administrative burden allows people to get into the joy of what they got into. Do I think we should be constantly hammering? I think we need to also not continue to add more patients to already overloaded schedules and allow opportunities for humanity and connection, yes, but I don't think a lot of, from what I hear from my colleagues in medicine, they're frustrated. They just don't have the time to do the meaningful encounter. It's all the administrative burden, and at the last minute, they have to move on to the next patient.
And sometimes we think about administrative burden as, I think our mental models, and certainly for me, I always think of paperwork. But I'll give you an example of something that we're exploring right now. It's the use of avatars for certain types of things that take up a lot of nursing time that's very routinized. And so, for example, post-discharge management of a Foley catheter and the removal of that, right? So we give instructions to patients, and nurses will literally call every patient and walk them through a set of instructions. And you talk to a nurse, and they'll say, "Oh my God, I can do that in my sleep. I just I'm just like reading the thing." And so we're looking at, and that takes them away from being able to do the in-person kind of things that they want to be able to do for something that arguably maybe an avatar could meet a patient where they are and gives them everything that they want in terms of, the ability to communicate with them. So we're looking at voice avatars as well as even like a digital representation of an individual to be able to say, how do we understand? Some patients may like the individual or the human rendition. Some people may just want the voice, but the ability for them to just hear it, ask some basic questions, get a response back, frees up the nursing time without any deviation from what's available to the patient, and arguably it gives patients more access because they can access that according to a better time for them, rather than I missed the call again with the nurse, right?
But this is
never going to be
exactly what I'm talking about. I, as a patient and as an advocate, as a care partner, I want to hear about these things, and we're not celebrating that. Everyone here has LinkedIn profiles.
Well, we don't have it in production yet.
So. Well, okay. Well, so we'll be looking
but those are the opportunities.
There are things that are happening that are bringing more joy back to medicine, more meaningful encounters. We should be talking about that, celebrating that. All we hear about it's hallucinations, it's wrong, it's going, and all the horror stories.
Totally
but
agree.
We need to tip the scale, neutralize the environment, and celebrate the good. So I would ask everyone, please celebrate the good work that you're all doing, so that patients and advocates and communities and nonprofits can see that, because that's a conduit for trust as well.
Right. And unfortunately, in the way that our system works in the U.S., I think most patients' experience with AI is that it's being used to deny them something.
Yep.
Yeah. And I think that's so interesting. And I think to celebrate something and answer the question, I think looking at some things that folks at Google are building in collaboration with scientists are things like addressing how to get patients to what they need quicker, instead of spending so much time calling the wrong person to get something scheduled, or seeing all of these providers that aren't the right people. And one example that was a collaborative effort between Google and some folks at Stanford was AI augmented triage to identify who actually needs to see specific specialty care, so that the specialists are only seeing patients that they actually can really help, and making sure that those patients have, they have the right imaging already done, or they're not getting routed to the right place. So easing the pathway for patients and providers so that the right people meet at the right time to get the right clinical care.
Well, then can I ask you a question about that, maybe both of you? When you think about, again, just making it more practical in mental health, we screen more now for patients with anxiety and depression, as we're aware of it, and then patients come up screening positive, and there aren't enough mental health professionals around. So I mentioned earlier about chatbots. Do you say, okay, that's good enough. And because there are no other mental health professionals, right, that we can use digital medicine, so to speak, I'm using the term broadly, so they get some level of care, although it's not a person, but it's better than no care. How do we evaluate that in terms of innovation?
Yeah, and we need to ask patients and talk to them about it.
Yeah.
Here's what Google did that I just want to point out, there's a very fine nuance. When that video started playing, did anyone say, oh my God, is that person smart enough to use the tool? Oh my God, is it going to hallucinate? No. We trusted the patient to use the tool. So I think when we talk about trust, trust the people too, and find ways that we can help people trust themselves to use these tools, empower them to be able to be agents in their care. And we're seeing that. People are capable. Some people do need support. That's our job. Fill in the gaps so that we level the playing field and upskill everyone together, and then drive patients and families to be partners, proactive partners and members of healthcare, U.S. healthcare, and partner with their physicians and care teams.
That's fascinating because it's really like patients as customers of healthcare. What do the customers, the patients demand from health systems? How can we get AI to help that? And that addresses, I think, part of John's question. And I think each environment, if you have, this goes back to a theme we've had where if you have no healthcare, maybe something's better than nothing. If you have good healthcare, maybe you're going to have a different bar. This is fascinating. Other questions? Yes, we have several. Okay.
Since John mentioned mental health, while we're getting this next question teed up, the FDA, I'll give a plug for the FDA, is going to have a meeting of their Digital Health Advisory Committee, I think next month. It's going to be focused on AI and mental health. So it should be a really good session focused on the mental health issues, both with respect to access as well as the complexities.
Hi, thank you so much for this amazing panel. I'm very inspired by just hearing about all the innovations you've worked on and led. One of my curiosities is, you know, you all sit in positions where you're seeing so much innovation, and I'm curious, what is some space where you feel like no one's really working on or focusing on that remains a huge problem that you wish a developer or someone else would address?
Okay, let's do lightning round answers to this and then close up. Grace, you want to start?
We have a right to try pathway for pharma and for drugs that may not have gone through clinical trials. We have no right to try pathway for an innovation that a patient may have come across and wishes to bring to a health system. And that drives me crazy. So I just to give you context, I work with CancerX, which is using the power of digital health to reduce the incidence of cancer, deaths by cancer, and connect people to quality and more affordable care. We have some fabulous startups that come through our accelerators. And if I have personally seen this, wanted to bring a solution to a patient who is sent home to die, who's not ready to die and wants more information, shutdown after shutdown after shutdown. How do we support innovation from the bottom up and trust patients and have a right to try pathway?
Amazing. John?
I wish we were doing more in prevention, especially in terms of lifestyle medicine. I think too many of the tools that we're seeing there are for those people that are already interested in prevention and we're in some ways just getting the healthier. And I think that's an area where we need to see more innovation in terms of getting preventive skills and tools to those people that really need it.
Yeah, I guess I would mention two things. One is we talked a little bit about it, but I think we don't spend enough on access in general and thinking about that trade-off. Partly, I think it's because of the way we pay for healthcare, the privacy issues related to that anything that is patient-facing that isn't provided to you by a covered entity, like a health insurer or provider, is not covered by HIPAA, and that presents a huge challenge for all of us, and I think is going to be a high friction point as we think about these kinds of solutions. But I think that we don't spend enough time on that. The second is, if you go into any place, and I'll let Sneha comment on Stanford, but Mayo in some ways is a microcosm of the healthcare system at large, which is to say, if you look at where the AI activity is, I mean, it's all across the board at Mayo, but most of the solutions we have come out of cardiology, radiology, and neurology. And if you look at the FDA approvals, 90% of those are radiology solutions. So we don't have enough activity in these other areas that in general don't get the type of resources in the US healthcare system. And the same is true in AI as well.
What an incredible discussion and panel. I want to thank you all. And I have one final question for you before we end. One takeaway from this panel on trust and innovation that you want the audience to leave with. Micky, why don't we start with you and work backwards?
I guess I'll come back to the thing I said at the beginning, is I think that we really need to be looking really, really hard at the misuse, at what opportunities are we denying patients by not using these technologies to raise the standard of care?
I'm going to steal Bakul's line from the last panel that really has been pressed upon me, that we briefly touched upon, that I think we really need a rich discussion here, particularly in Washington. Do you try it before you regulate it, or do you regulate it before you try it? I think that's the future discussion that we're really going to dig deep into.
Grace. How many people here have a chief patient officer as part of their leadership? Raise your hand. That's a problem. No one raised their hand. So your homework is find a budget, hire patients, compensate patients, hire a chief patient officer, not just for your AI efforts, but for all the efforts for innovation and technology. And then you can have task forces, you can have workbooks, and we can all share best practices. But until we include the patient and care partner voice, we're going to keep running into the same implementation, adoption, design problems.
Thank you so much. And with that, we will end this session. And thank you all for the fantastic questions and conversation. Thank you.
Thank you, everybody, that was such a great panel. Thank you, Dr. Jain, and all the panelists for the reflections and recommendations. I also scribbled a ton of notes on my card here. But the conversation about trust, different stakeholder perspectives, the connection to payment, value, so many interesting and important learnings. So thank you very much for that. So it is now time for lunch. So lunch is going to be served at the back, buffet style, and we encourage you to come back to your seats. There's also some seating available near the buffet as well. We will begin our next session promptly at 1:15. So thank you and enjoy lunch very much. So thank you, everybody. Please take your seats. We're going to transition to our final session of the day. And this panel is going to focus on opportunities for sustainable and accessible AI innovation. And Dr. Daniel Yang will be moderating this panel. He is Kaiser Permanente's Vice President for Artificial Intelligence and Emerging Technologies. And in this role, he ensures quality and safety for AI applications across clinical, operations, research, education, and related administrative functions. Before joining Kaiser Permanente, he directed a diagnostic excellence program at the Gordon and Betty Moore Foundation, where he helped establish several public-private partnerships to promote responsible use of AI in healthcare, including the National Academy of Medicine's AI Code of Conduct and several other public-private partnerships. Dr. Yang is also a practicing internist, so let me pass it to you, Dr. Yang.
Thank you, Ceci. All right, hello, everyone. This is the last session, and we have an amazing set of panelists here. We were just struggling to figure out what hasn't already been discussed and deliberated on, and so I think the opportunity here, one is we're in DC. We have a space to really talk a little bit more deeply about the policy implications around health AI, both how we set appropriate guardrails to, I love Micky's framework of navigate both minimizing the misuse of AI, but also minimizing the misuse of AI. And I think policy has an important role in helping us figure that out. And I want to talk about AI divides. And there's two AI divides that I want to cover. One is really at the organizational level. We've had amazing organizations like Mayo, Stanford represented, organizations with a tremendous amount of resource and expertise. But those institutions don't necessarily represent what care looks like in the rest of the country. And so how do we ensure that the benefits of AI are felt across the country? And we have Jennifer from Ochin to help us walk us through that. And then the other AI divide I want to talk about is really the divide between patients using AI, relying on it every single day, which we've been hearing about, and patient trust in health system use of AI. And I think there's some differences there. So how do we navigate that side by side? So I'm going to ask each of the panelists to introduce themselves, share a little bit more about your organization, where you come from, and how you're thinking about the current moment of AI in healthcare. So Jennifer, I'll start with you.
Thanks, Daniel, and thank you to KP for having me here. I'm Jen Stoll. I'm the Chief of External Affairs for OCHIN. If you're not familiar with who we are a national not-for-profit health IT and research organization, and we have successfully knit together hundreds of disparate organizations into basically what is a delivery system of underserved and rural providers across the country. We provide all of the health information technology support on the back end for federally qualified health centers, public health departments, critical access hospitals, very large growing critical access hospital footprint, as well as tribal communities and other ambulatory providers. And so when we think about artificial intelligence, we're thinking about the opportunities that it has in our section of the delivery system to really reduce costs and improve care. But we are thinking about it in a way that really helps support our members where they are. And one of the challenges that our section of the delivery system faces with AI is being able to navigate the complexities of these systems and understand where they are across the country and in the regulatory environment that they're addressing. So we're helping them with compliance, we're helping them with data use agreements, governance structures, and really thinking through these are not just other tools that they're going to add on to their current structures. So they are just under-resourced overall, whether you're rural or an urban provider, and particularly they don't have medical ethicists or 300 people developing tools or writing code. So they're really looking to us as their trusted partner to be able to support them in this journey. And we are excited about it, and we're also wanting to make sure that we are responsible and building trust as we are considering what are the right tools to solve the problems that they're facing today.
Thank you. And Jennifer, can you just remind us the scale in terms of number of organizations you support?
Sure. We have over 300 unique tax ID'd organizations on OCHIN in the OCHIN network, and over 45,000 providers that we are in service to, and about 10 million patients across the country. We represent about 1/3 of the FQHCs that we provide assistance to, as well as I said, a very large and growing footprint in rural critical access hospitals.
Thank you. Kedar.
Well, like Jennifer, let me say thank you to the organizers. Thanks, Daniel. Thanks to KP for having us here and having me on this panel. So Kedar Mate, I'm an internist, faculty at Cornell Medicine and at Stanford University. There's a little Stanford vibe in the room as well. And I've had a couple of different stages to my career. I was in global public health for a long time, then in the healthcare policy world, and most recently was the president and CEO of the Institute for Healthcare Improvement, a quality and patient safety focused organization that had a long relationship with Kaiser Permanente, almost 20 years. And then I got an itch that I had to scratch, which was to try to figure out how the present generation of artificial intelligence is going to help shape the healthcare landscape going forward. So in the beginning of this year, in January, there seems to be a kind of moment in the room. There were like 2 previous panelists who had new jobs as of the beginning of this year. I'm also one of those people. So in January, began with a handful of colleagues at Stanford, a new company called Qualified Health, which I'm a co-founder of, not the only founder of, and now the chief medical officer. And Qualified Health really began as a governance, safety, and security organization. It was focused on helping health systems of all sizes and shapes adopt generative AI solutions and syndicate them across their enterprise, but doing so in a manner that was safe and secure across an enterprise. And what we quickly found was in the early stages of the company, there just weren't as many solutions. We didn't have 375 applications yet running in the ecosystem in most of the health systems that we were talking to. Most systems just didn't have that kind of volume yet of AI tools. And what they needed was some of those applications. So we built an application layer, helped with data infrastructure, and are now wrapping all of that with a governance solution that allows for safe deployment of these technologies in the environment. So that's Qualified Health, a platform company that's helping health systems adopt these technologies. It's great to be with you.
Thank you, Kedar. Brian.
Well, first, thanks for having me here, Daniel. So I'm Brian Anderson, President and CEO for Coalition for Health AI, or CHAI, like the spiced tea, or if you're Yiddish, Kai, like life. CHAI was started 4.5 years ago in the middle of the pandemic, and it was in that setting that you had a lot of public sector officials and private sector officials working together in Operation Warp Speed, solving the pandemic that was in front of us. We realized the impact that we were having, and we quickly asked ourselves, is there something more that we could be doing? And we asked, we looked at AI and we asked, do we have consensus across the private sector on what good, responsible AI looks like at a technical level? The answer we quickly came to is we don't. We have a lot of really good work happening in different health systems and different technology companies, but not a common definition of what good is. And I think all of us agreed at the time that in health, that's something important that we should have. It's a pretty consequential sector. And so that's been our mission, is bringing together, convening a multi-stakeholder group of health systems, doctors and nurses, technology companies, big and small, patient community advocates, nonprofits, working together to build that common definition of what good, responsible AI looks like. And we try to do that looking at a model's life cycle. So if you think of a model's life cycle in 3 basic phases. So there's the development phase with tech companies, there's the deployment phase with health systems, and then there's the monitoring or governance phase longitudinally. And each one of those phases, we want to think very carefully, what does good development look like? What does deployment of a model in a very complex clinical workflow look like? What are the KPIs to monitor this model? How do we think about risk as it relates to that monitoring? Is it something that we need to monitor a model in real time, or can it happen on a monthly or a quarterly basis? So these are some of the equities and considerations that we do in the convening and bringing together various stakeholders to do that. We started with 8 organizations. We now have over 3,000. I think we're the largest health AI coalition on the planet. And it's an honor and a privilege to work alongside so many amazing organizations. Every one of these panelists here with me, we're working on that together. And so that's really the mission of CHAI, is bringing together different stakeholders who might disagree, but building consensus where we can on what that definition is. I'd say, the other thing that we do, and I think this is really important, is educating our providers and nurses and patients on how to navigate this AI landscape that's changing so quickly. We announced recently a partnership with the Council for Medical Specialty Societies that represent over 50 specialty societies for physicians, and building out responsible AI curriculum for them. I talk to providers every day, and many of them struggle with a very basic question, which is, in the AI world, is this AI tool that I could potentially use the appropriate tool for the patient I have in front of me? And many providers can't answer that question, right? Because you lack basic information like, was this model trained on data that is representative of the kind of patient I have in front of me? What are the indications and limitations for the model? What is the intended use for the model? How does the model perform? These are some of the basic questions that we're trying to empower physicians and nurses and patients to be able to know and understand so that they can have informed conversations with their providers.
So Brian, I'm going to ask a follow-up question. I'm sure many in the audience may be aware of CHAI, at least if you follow the health AI space. You guys have been in the news recently. There's been some pushback on CHAI, particularly coming from the administration. So I'm wondering if you could, share a little bit more about what's the nature of these concerns and what are your thoughts about them?
Yeah. Thank you for the opportunity to speak on that. AI is moving so quickly, and I think it's very easy to misunderstand different things about AI or organizations. CHAI's mission from the beginning has been to build consensus on what good, responsible AI looks like at a technical level, and to do that with startups, to do that with patient community advocates, to do that with health systems, big and small. And we do that through these working groups, building those technical best practices. And people disagree. We don't have an agreement on everything. And I think, but it's through that disagreement that we build consensus. And so that's what CHAI is. We also believe deeply in informing and partnering with the public sector. I think everyone would agree in the room, particularly here in DC, that we want our regulators, our policymakers to know where the innovation community is moving. The emerging capabilities of Gemini or ChatGPT or Claude. It seems like a new emerging capability comes at least once a quarter, or new use cases. We don't want regulation to be misinformed by where innovation is moving. And so we believe deeply that CHAI needs to have a seat at the table for our public sector to participate. And when the administration changed over, we were very excited about the level of engagement from CMS to FDA to ASTP ONC. We were literally working alongside all of the organizations. Now, I honestly don't know, I think, where the misunderstanding happened. But again, if you follow the news, you know that we've certainly been receiving a lot of, I think, critiques and criticism. I think it's important for all of us, certainly in this space, to have a level of humility that we don't have all the answers, that we need to learn from each other and share best practices or how individual organizations are navigating this space. If there are criticisms of CHAI from our public sector colleagues, I want to know what those are. I want to make a better public-private partnership. I want to create a safe space for our regulators and our policymakers to be able to participate so that we can more better align whatever it is that we're doing in a working group to, promote, support, accelerate the President's AI Action Plan, as an example. CHAI is not a regulator. We have no aspirations to be a regulator. We are not a cartel. We build consensus through voluntary conversations and the technical products that our coalition brings together. That's been the mission. That will always be our mission.
Well, can you just, for the audience that maybe not tracking the day-to-day news, I mean, what is the nature of some of the critiques that you've been receiving?
Yeah, I think there's a misunderstanding. When CHAI launched, we started under the Biden administration. And as I said, we wanted to create a space where the public sector could participate alongside, tech companies that were moving a mile a minute, innovating. And so ASTP ONC and FDA joined our board. And we thought that was fantastic. As federal observers, they should be able to understand where CHAI is moving and where our community is moving. I think, I don't want to speak for ASTP or FDA, but there was, I think, some concerns that working that closely in this space might, have a conflict of interest. And so totally fine, they had to step back, but actively continued to be part of all of our working groups. I think there's a misunderstanding with the current administration that we are somehow, a Biden-era only effort, which is not the case. CHAI is bipartisan or nonpartisan, and so we've been actively working with the current administration in many ways. But I think some folks thought that, because of our work with the Biden administration, that CHAI wants to be some quasi-regulatory, outside of government entity. And you can follow the press and take a look and just hear from me that that is not the case. We do not want to be a regulator, but we want to work with regulators and we want to inform them. The collusion comment about being a cartel, I honestly don't know where that comes from. We are not a cartel. And, what we do is we bring together organizations to share and to build consensus. It's voluntary in nature. I think maybe the concern might be, well, gosh, you have over 220 health systems, right? The vast majority of America's healthcare delivery organizations are part of CHAI. I would say they are part of CHAI because they want to learn from each other. It's not that they're creating some antitrust, collusion. There's no money being exchanged hands in that capacity at all. So I think there's a lot of misunderstanding. I think, certainly today in the environment, we need to learn to disagree better. I'm not the first person to say that. There's a lot of, I think, comments out there that are disturbing and concerning to me personally. So I hope we can find a way through it. The administration knows that we're more than willing to sit down with them. I've sent messages to Secretary Kennedy, to his deputy secretary. I want to build bridges to them and build a better partnership with them.
Thank you, Brian, and appreciate your kind of transparency and honesty in addressing those issues. This is a space on this panel that we want to really have an opportunity to discuss and debate these very issues that I think CHAI is working on. one of the issues that was flagged is on this notion of regulatory capture, this notion of, whether it's the regulators themselves, whether it's, quote, pseudo-regulatory bodies, may position the certain organizations better to deploy AI in a way that benefits the members or the people they serve at the expense of others, right? So this notion of haves and have-nots. And this is a theme that I've been seeing play out, and it's something that honestly worries me, not on the innovation side, but on the health system side. Whereas I talked about, what attracted me to KP is our size, our scale, our research expertise, our data assets. What makes KP unique means that KP in some ways is not representative of the capabilities of every health system across the country, including some of the organizations, Jennifer, that you serve and support. And so, this notion of an AI divide where the benefits of AI may only be felt in certain pockets of our country or for patients of certain health systems, but not others, I think is a growing concern. And so number one, Jennifer, as an organization at Ocean that supports lesser resourced organizations, how do you think about the AI divide? Is it real? Is it imagined? And what are ways or strategies to mitigate that AI divide?
Yeah, thanks for the question. It's a good one, and we strongly believe that AI will actually accelerate a divide. And I want to just back up really quickly to be able to share one of the greatest challenges that we, as an organization, especially in our rural communities, when we walk in to support the community where they are, we find that they're on an EMR that may be on break fix, or they're not interoperable in any way. So they may be on 2 or 3 different systems, the clinics, the acute care, the skilled nursing. They're on disparate systems. And, the challenge of having quality data that allows them to participate in AI and really meaningful, and Micky talked about workflows, or John talked about workflows, none of that is possible when you're on these disparate systems to begin with. So I think about a lot of the work many of you in the room are doing in terms of you're in full sprint mode. And many of the communities, particularly our rural hospitals, are back here. I mean, they're starting in P20. We're big Formula One fans in my house, and they're starting in position 20, and you guys are starting in P1 and P2. They're never going to be able to catch up. And so, thinking about this, and I'm excited with the Rural Health Transformation Fund being able to maybe help those that are on older disparate systems be able to upgrade their systems. At least they can start closer to the front of the pack. Maybe they're starting in the middle of the pack. But unless we help those that have older infrastructure, IT infrastructure, move ahead, we're going to constantly have this, we're catching up. I also think that we are thinking about AI in terms of having trusted partners. Not everyone has to do what Mayo is doing or what Stanford's doing. But if you have a trusted partner that that can help guide the conversation and support you, that is going to be critical to being able to keep up with the AI changes, because there is still a lot of hype that these things are going to solve every problem in the world. And we forget that, maybe it's an AI model, or maybe it's just good HIT, or maybe it's having people that are trained to know how to put the data in to begin with. These things are a continuum, starting with good infrastructure and starting with a trained, skilled workforce, which is the other big gap that we see in our section of the delivery system. Now, we're excited about AI to being able to support both of those things, but it's not the solution. It's an answer to a larger question, a larger continuum. Starting with good infrastructure and then building is so key to making sure that we can, I don't think we're ever going to be together, but at least we're not going to be so far apart.
Can I just ask a follow-up question? So we were talking about this yesterday, where you talked about, a lot of the FQHCs are just starting at a infrastructure deficit, may not even have the EHR capabilities to manage routine care, let alone, some of the more advanced uses of AI. And so we were talking about this concept of the Maslow's hierarchy of needs. You know, it's like first you need basic food and housing before you can consider self-actualization. And the idea is, hey, well, maybe getting your EHR infrastructure in order is the equivalent of food and housing. And AI is higher on that thing where once you've settled that core infrastructure, you can work on those other things. I guess the question is, can AI help expedite the progression from, you know, yes, we have deficits in EHRs and infrastructure that's only growing. Can AI itself help to level the playing field or leapfrog some of the infrastructure investments that the KPs, the Mayos, and others have been making over the last 20 years? Or will it only just worsen the divide?
So we think of it in terms of what problem are you trying to solve, right? You also have to remember, too, we don't have the staffing that the large delivery systems. Most rural hospitals, again, are, you know, they don't have the pool to recruit from if you're in a rural community. And, you know, they don't have the same number of people. You're talking about wearing multiple hats. It's other duties as assigned, right? And so then you're saying, okay, well, now you need to know AI, and you're going to need to have all your data use agreements, and you have to think about it from an enterprise structure, and what are you solving for? And now you have to know all the different things that are potentially AI-enabled, right? And this is where having a trusted partner is going to matter, right? And somebody that can help guide the journey of what are you trying to solve for? And then applying the right models on top of a high-quality infrastructure will help build onto that, so that you can actually think through, how do I drive community health? How do I drive chronic disease to be able to align with the needs of my community? What do I need to lean into? What do I need to... so I think about build, buy, and partner, right? What do I need to build? What do I need to buy? And what do I need to partner for? So being able to think of that in the continuum when it comes to health IT. AI has the promise of being able to solve big problems, but it needs a good quality data set to feed it. And then the last point I would say is, you know, we think about trust, right? And trust comes from, did this work in my similar environment, right? And so one of the things our members are asking us to do is make sure that these things are piloted, that we have knowledge about them before we're deployed in mass. So, you know, we have 2 large language models that we have partnerships with that are integrated into our system. And one, when we piloted it early on, that we're talking about almost 3 years ago, did not speak Spanish. And in the Ocean Collaborative, almost 50% of the encounters are done in a language other than English, and that's a problem. So when we think about, like, can you get trust to these solutions if they're not even able to speak your language, we're starting with a deficit already. So thinking about these as solutions to rapidly solve problems, we've got to make sure that they're validated, they're tested, and they're in a trusted environment so you can build on them, too.
I mean, on the other hand, there is the possibility that the AI tooling that we have now can accelerate the ability for us to, for example, translate into 127 languages as some of the tools that are on the market. I think there is a really interesting, this is actually sort of an unknown, right? Will AI worsen the digital divide, or will it reduce it? If you talk to the optimists, of which I am one, I would say that, you know, AI will help us to shrink that divide by virtue of, you know, creating democratization of knowledge and true commodification of that knowledge, so that we can get cardiology specialists, as we heard about on the prior panel, into every county in the country. But, you know, the equivalent is also potentially true, that we will end up with the Mayos and Stanfords and Kaisers of the world who have the ability to resource and create 300+ models and algorithms in their environments. And then we will have your constituents and stakeholders in the FQHC system that won't have the ability to create nearly as many applications and won't have them deployed in their environment. We may end up with a scenario in which we have a truly 2-tiered system in which the chatbots, you know, treat the poor and clinicians treat the sick. You know, the human clinicians treat the wealthy, sorry, that is. And I think that's a real uncertain, we don't really know which way we're going to go here. I think we have some choices to make about how we distribute this technology, how we train it, how we distribute it, how we provide access to it, how we advance real, sort of to Brian's point earlier, how we come together to actually understand accountability and trustworthiness of the technology. Those are the choices that we have today to help us ensure that the path that we end up on is one where the digital divide shrinks rather than increases over time.
Brian, I'm going to ask you a follow-up question on this, which is one, CHI includes in its membership groups like OCHIN, as well as the National Association of Community Health Centers, as well as the Mayos and KPs and Stanfords of the world. So one, how are you seeing this play out within your own membership? And two, back to the policy question, when I'm asked to represent KP's interests to policymakers, one of the things I try to warn people around is that policy itself can worsen the AI divide. If you set a regulatory bar where only a handful of organizations can meet, you are inadvertently putting most health systems under that bar, which only exacerbates, the infrastructure deficit. Now they have a compliance deficit to add to that. So two things. One, what are you seeing, across your membership in CHI? And two, as you're having conversations with policymakers, how are you asking them to navigate this issue?
Yeah, on the how is it playing out across the membership? Within the FQHCs and the critical access hospitals, frankly, as well as the larger academics, this concern around governance. I think Micky had mentioned it, the longitudinal management and the financial cost that a health system bears when you procure a model. That's one upfront cost. But the management and maintenance of that is a real burden, not only from a financial infrastructure standpoint, but also subject matter expertise, right? I used to work at an FQHC. We did not have technical experts, on standby that were going to be monitoring dashboards and, measuring the KPI or the AUC as it drifts or degrades for models. And so a lot of the health systems that are lesser resourced see this as an existential moment. How do I, I'm hearing from my board, I need to get into the AI game. How do I do that and do that in a sustainable way? And so I think that's a real concern, particularly for the federally qualified health centers, the critical access hospitals, the rural health clinics. Like Hadar, though, I'm an optimist, and I'm really excited about the potential for AI to meet those health systems and those community and the patients where they are at, right? We've talked already about the access and the potential benefit of agentic models to be able to deliver higher quality care. Hadar, I would position it as like those chatbots could actually deliver better care.
I think that's that is also an unknown, right?
Yeah.
Which one would be better? Right?
And so I'm excited to kind of see where that goes. But I think the health systems are deeply concerned about the financial sustainability in that space. And so to that point, when we talk to policymakers, I think it's one of the things we emphasize is that we need to have intentional policy at the infrastructure level that supports and enables those kinds of health systems to be able to participate. How are we going to get the data to train models on patients like those in rural communities, right? Because the vast majority of data that the model developers have access to is from highly urban, highly educated, rich communities, right? Urban communities. And it oftentimes doesn't come from rural Appalachia. And so we talk a lot to representatives in the House and the Senate about how do we create the infrastructure to make that kind of data available in a privacy-preserving, de-identified way, but in such a way that the models that can be trained can actually help those communities. The other part is how do we create the kind of infrastructure and support to manage these models? To your point about regulatory capture, what we don't want is to create such a high burden and bar for health systems where, I'll make something up, every AI model you deploy, health system, you have to have real-time monitoring for everything from, the AI model that manages your logistics for Q-tips and cotton balls to, the sepsis model in the ICU. Of course, that doesn't make any sense. But there have been conversations about how robust does the monitoring need to be? We're working with organizations like the Joint Commission and health systems themselves, as well as specialty societies, to come up with better frameworks on what that kind of, what does robust and rigorous governance mean, such that it's not going to disenfranchise the critical access hospital, that they can actually do that as well. And so I think those are the kinds of natures of conversations that we're having.
Well, I want to continue the conversation around post-market surveillance. There is a lot of faith and discussion around it's hard to manage from a pre-market perspective. We heard that in the last panel, all of these different AI use cases coming at us. So perhaps we can manage it on the back end where let's put these tools into practice, let's see how they work, let's collect evidence, and Sneha was talking about this as well, collect evidence both around effectiveness but also safety. And so I can see the appeal of it, but I think the question is how close are we to having the infrastructure, the incentives, the know-how to actually do the real-world post-market surveillance? What would need to change to get us there if we're not there yet? So just thoughts on how far away are we from that policy objective?
I mean, I think we're actually closer than we might think. This is a bit of what we do in our company is to help organizations manage the risk post-deployment with monitoring tools that are technology enabled. I mean, one critically important thing to know is that the vast majority of sort of how health systems think about governance, I'm not talking about the Stanford Mayos, Kaisers, et cetera, but the vast majority of health systems have established a committee, and the committee meets once a month and reviews what technologies they're planning on deploying and how they're performing in a general sense. That is far from adequate in terms of understanding how these models are performing and how they behave in our environment. If you have a health system with 1,000 employees with 10 algorithms in motion that make 10 or more calls to an LLM a day, that's 100,000 calls to an LLM. How on earth is a committee that meets once a month going to manage and monitor the hallucination rate and the escalation rate of that type of geometry of a problem? So you need technologies that help you to conduct that, and you need to do that efficiently. I don't think the problem is cost. Actually, I think these are not particularly expensive tools to have deployed in an environment to help understand whether algorithms are performing up to standard. We're at the early innings, I'd say, of generative AI monitoring, but these are from a predictive AI or sort of pre-generative AI. This is not new technology to monitor hallucination rates and escalations and edit distance and so on. So the technology exists to do this, and what we need to make sure that we're doing is ensuring that everyone has access to it. And I think this is a reasonable place for policymakers to support health systems of all kinds to offset the costs of actually deploying that type of technology. So, for all of your members, as well as all of your members, the ability to kind of monitor and understand the performance of these algorithms in their ecosystem is going to be vital to scaling them in the enterprise and knowing where the risks might lie. And that's, I think, a reasonable place for policymakers to say that's something that we can support through real incentive and dollars.
And let me just kind of expound on that. When I'd mentioned that the cost, the financial prohibitiveness of it, I was referring to, so when health systems started first procuring AI, many of them were big academic centers. And many of those health systems were like, great, okay, we need to do governance. We have the committee. We need to stand up the infrastructure. I can count on more fingers than I have available how many health systems tried to do that. And inside of a year, they were expending more than $2 to $3 million. Quickly realizing it's not sustainable. And it was candidly organizations like Qualified that have now begun to make that, to your point, more of a sustainable future. And so part of the education that we're bringing to the policymakers is how do we create a competitive ecosystem of these kinds of providers that can meet the critical access hospitals, the FQHCs where they are, to provide that as a software as a service capability. In the post-deployment or post-market surveillance, this is, I think, a very important area of focus within CHI. There are so many AI tools that are being adopted across health systems, and there is so very little understanding about how those models are actually performing across different clinical sites. And that's a really key point. If you are able to identify a variance or a delta in the effectiveness or the accuracy of a model from one health system to another, that begs the question, why? What is one health system doing that's better than the other? And what can we learn from that? And so in CHI, what we're doing is we're going to be announcing this. I can share a little bit of inside knowledge. We're going to be announcing a major effort in November, standing up the first, what I think is the first post-market or post-deployment monitoring network of health systems. There's about 24 of them that have already raised their hand and said, yes, we want to participate in sharing anonymously data on how these models are performing at our sites, with the hope being that those that are doing exceptionally well can help teach those that might be laggards. And we can, again, collectively learn from that. It's something that we've been having conversations with folks in the regulatory space. As I think everyone knows, the FDA is kind of the regulatory body that does post-market surveillance. I think they have an RFI out for what does that mean for AI, and we're looking forward to helping enable our members to be able to participate in that conversation. Right? It's working with organizations like Qualified to be able to get that kind of insight and then build consensus and understanding about what the best approaches are to get the AUC to the 0.95.
I mean, one thing, just to give you an example within the KP environment, is the fact that we are in 8 different markets is a huge advantage. And there is asymmetry in the size and capabilities of some of these markets. So Northern California, where Vinny is Chief Data Officer, is a massive organization that serves 4.5 million members. And so when we deployed, for example, the ambient scribe across the enterprise, we were able to take lessons learned in some of our larger markets that we learned within weeks that would have taken some of our smaller markets months to learn. And so we were able to harvest those findings, share it almost immediately, and not just what was not going right, but what the mitigations were or what the educational materials back to the providers were. And so I think there we were really able to leverage our national footprint and kind of create in our own system of post-market surveillance to identify these issues. The issue, though, is that it feels like we have to stand up that infrastructure anew for every new use case. And so when I hear Micky saying we've got 375 use cases, the natural thing is, well, do you have one governance infrastructure to do monitoring across them? At least in my experience, it feels like a custom set of performance measures, reliant heavily on Excel spreadsheets and SharePoint. The asymmetry between the amount of investments of venture dollars and innovation on deploying use cases compared to the amount of investments and innovation on the governance and monitoring of this. And so I kind of feel that asymmetry every single day where new tools are coming out, but our ability to manage those tools are not being resourced with the same level of enthusiasm. I don't know, Jennifer, if you feel the same.
I mean, we're talking about post-marketing surveillance. I want to back up to say affordability is a big challenge just right out of the gate. Right now, it's an and and an and and an and and an and. Everything just keeps adding costs. And if you are, in a rural, low-resourced environment, these things are very, very challenging just from an affordability standpoint. So, we've been thinking about how are we measuring return on investment on what they're actually buying, and particularly their whole tech stack, and what are they thinking about from soup to nuts, and an enterprise structure, and being able to measure the return on investment. And then we still have post-marketing surveillance on the maturity of these models. But if we don't look at the cost effectiveness and we don't look at how we pay for things in this country, that's a whole nother can of worms, right? We're going to continue to keep having that divide. And this is why I'm not so optimistic that we can close it. I think we can get closer with AI, but I don't think we can ever.
Yeah, I mean, I don't disagree with you about this. I think we're sort of honing in on the post-market surveillance opportunity, but there's a bigger upfront opportunity to stimulate growth and adoption of AI technologies across the spectrum of delivery environments. And we have to similarly, whether it's through RHT or through some other mechanism, similarly incentivize health systems that are in the FQHC system or in the safety net, and not just incentivize, but provide them with real economic resources to actually use these technologies, to buy them, to deploy them, to monitor them, all of the above. So it's not purely a monitoring and surveillance question. It's also an upfront question around affordability of these technologies, so that we don't end up with this, two-tiered, digitally divided health ecosystem in the future.
Yeah, I mean, I'll give you one example again from Kaiser Permanente. Partnered with some 30 federally qualified health centers and the state of California to create what we call the Population Health Management Initiative. And we were one of the funders. And what we tried to do is upskill these FQHCs with population management, health management capabilities, which include not only just support and connecting them with the vendor, but also all the implementation work that surrounds just beyond the technology. And it was the same concept with the High Tech Act. It wasn't just money for systems to buy EHRs. My understanding is they had regional extension centers. There was implementation support, because that's where a lot of the challenges, and I imagine, that's the bread and butter of what OCHIN does.
Yes, and you're speaking of meaningful use and EHR incentive programs. I mean, we're very familiar with that. But you were also talking about an immature market where we put capital out for providers to select in an immature market. And even as a regional extension center, we couldn't say, okay, here are your choices. This is the one that best fits. We weren't allowed to kind of guide that conversation. So, I think about AI as an immature market. What is the right policy approach in terms of incentivizing what products when we're seeing a lot of consolidation? A lot of us are trying to solve for the same things. How do we let the market kind of settle a little bit and mature before we start incentivizing? But we don't want to get left behind either. These are complicated questions.
But I think this idea, what I was hinting at, is really a high-tech V2, right? Is a sort of a similarly driven approach where there's a significant amount of capital infusion into the delivery ecosystem for wide-scale adoption of this technology. But if we truly believe that it is the transformational potential, generational, potential with this technology to transform what we do in healthcare, both for patients and for providers, we almost can't not place a significant bet as a country, I think, into the widespread adoption of this technology in the ecosystem. And that means, there will be systems that can afford to do this on their own, as we've seen in the market today, and there'll be a lot that cannot. And meaningful government support, federal support to health systems to achieve that type of transformation is going to be needed. I take your point, Jennifer, that we need to do that preparing the market so that we don't recreate some of the challenges of the past.
And we have to have a skilled workforce to be able to do it. And this is something that we've been thinking a lot about, is how are we making sure that low-resourced environments have the right skilling to be able to navigate this conversation. I mean, this is going to be the greatest challenge, is rethinking education just overall. And I know we talked about that.
Well, tell me more about that. How are you thinking about workforce and reskilling or upskilling within the safety net setting?
Yeah, and I want to thank our HRSA partners, because, OCHIN actually operates the California Telehealth Resource Center, and a big shout out for my team, who's done a great job doing an AI boot camp. And so there's some great tools and resources on ctrc.org, shameless plug out. So thinking about just getting everybody level set with basic education, what these things are, what they're not, and how that it impacts potential health care. I mean, we need to level set. We're not teaching this. We certainly don't teach it in terms of, hey, you're a biller or a coder. This is going to impact. Like, that's not part of our normal course of education. And so we've got to think differently about how we're bringing the right skills. And and we have tremendous trouble in keeping staffing in our section and delivery system. I'm really excited about upskilling not only providers, which we talked about this morning or earlier today, but being able to upskill the entire front desk staff, which has the highest level of turnover of almost any position in the clinic, to the back office staff. So, being able to be thoughtful about how we approach AI skilling, and we're hoping that this will be something that the states pick up in the Rural Health Transformation Fund, that they think about educating and workforce development around AI. And so as a policy, please ask for that in your applications, states. That's really key.
Can I just add one thing to this, which is that I think it's also just from the developer, now I guess I have the developer hat for the moment. It's still an unfamiliar hat for me to wear, but anyway, I'm wearing it for a second here. And I think it is actually on the developers to design tools that become easy to understand. It is one thing I don't disagree with you, Jennifer, that we should provide education and upskilling and support to staff. But if you think about your, Samsung or iPhone or whatever mobile device you carry around with you every day, there's no instruction. I mean, there is, I guess you could Google or YouTube an instruction manual for how to use your iPhone. But candidly, I discover stuff about my iPhone every day, right, on some level, or every couple of days anyway. And it's part of this is about the technology itself should be intuitive enough that it should also teach us how to use it. So it's a little bit on the designers and on the UI, UX folks and, the technology developers themselves to actually build intuitive technology that, a biller or a coder or an MA or a physician or a nurse or a patient will find intuitive to use. And that's, I think, part of the obligation here too, not just formal education, but through the technology, can we teach people how to use these technologies better?
Well, I want to push on that or expand that around another unspoken dance that's happening both on the stage and out there, is really the role of the developer versus the role of the deployer. And there's a lot of, I feel like, push and pull where, unsurprisingly, the health system deployer is often saying, hey, that should be a responsibility of the developer. And we're seeing the developers often pushing and say, no, that's for the deployer to figure out. Brian or Kedar, like, how are you seeing that dance play out? And are there clear guidelines around what are clear responsibilities of a developer of technology, and where does that line become gray between the deployer versus the developer?
Happy to go first. It plays out most clearly in CHI in the development of our model cards. So we believe deeply in trust through transparency, this concept that if we want to build trust and unlock the greater, more consequential use cases of AI in the ICU, as an example, we need to have greater transparency into how these models are created, the kinds of data sets used, how they are actually performing. But it's in that data set training, data inputs, that I think it's really illustrative, I think, the point you're trying to make. You have startups that are saying, well, we don't want to share any of our IP, right? Because if I share my IP, then someone's going to competitively take it and scoop my competitive advantage, and there I go. But to your point, you have health systems saying, wait a second, my general counsel is telling me that every one of my doctors is legally liable, that if that AI product hurts someone, that patient's going to sue my doctor, not the vendor. And so appropriately, the health systems are saying, before we make a procurement decision, we need a better understanding about things like what kind of data sets we're used to train, what are the indications, what are the limitations, what's the intended use, how does a model, there's a list of things that health systems really importantly need to know. And so what we've tried to do, and this is really following ASTP ONC's HTI-1 rule, is bring together the developer community and the health system community to, again, through disagreement, but building consensus on what is that minimum threshold of transparency that can build trust, that doesn't violate sharing IP, but that empowers providers and patients to better understand, the safest, most effective way to use these tools. And I think that's what we all want. We want these tools to be helpful to our patients. And so, that's how we're seeing it play out, right? It's not all rainbows and unicorns and we get agreement all the time. But we're slowly getting there in terms of what these model cards are looking like and how they can be helpful to patients, to providers. But it's not easy. I mean, it's a challenge.
I mean, I guess I would say this is part of how we're distinguishing ourselves. Part of our thesis as a company is to say that, it's no longer sufficient just to generate a very brilliant algorithm and leave it to the market to figure out how to use it. In our view, value is not derived or obtained by a delivery system or by a patient until it's actually put into use and taken up by either the provider or the patient or whoever the target stakeholder is. And that is actually, we see that as partially our responsibility. It's not us alone, it's not the developer alone, but it's the developer and the deployer together that actually are going to create the value. And it's no longer sufficient for us to say, here's the tech, good luck. It's just not the message that at least we're using as a company.
I mean, I'll just say, as someone that helps lead our responsible AI program for KP, it is a differentiator when a vendor comes and says, we're going to take some of the work off your plate. We're going to make it easy. We're going to give you the evidence to demonstrate safety and effectiveness. We're going to do or provide the infrastructure or the metrics for ongoing monitoring. If the technology, all else being equal, the differentiator really is the responsible AI by design and the transparency around it and the guardrails. Of course, for us, then it puts us in a position of verifying and oversight, but it actually takes away a lot of the burden from us, and it actually increases the ROI because, as we talk about, the cost and maintenance, is significant. So the vendors that are able to manage that well, I think, are, I would hope, rewarded in the marketplace.
Yeah.
I want to open it up to audience Q&A. And so I think we've got some folks walking around with microphones. I also have some questions here. But first, let me just see if anyone has any questions from the audience. All right. While you're contemplating, I think this was a question. These are the questions that we received from you all earlier. So we somewhat covered this, Jennifer. When preparing the future workforce to use AI as a partner, how do we build and foster trust between patients and clinicians? Are we moving towards a dyad to triad dynamic, and trust is a care component?
Okay, I'll do my best. I think trust starts with understanding what data created the model, and that's why as locally validated as possible and being able to test before scale matters. And then being transparent. We're a firm believer of transparency. One of the things that we didn't touch around in policy is what is happening at a state level, and I think this is adding, there is a different perspective at a state level than federal level across the country. It's going to be challenging to navigate 50 state laws around AI. I will say that, but it's because we need some guardrails at a federal level. I will also say that from a maybe controversial perspective, but not having some bumpers on the rails will allow us to bowl down the wrong lane. So we're a big proponent of being able to have national standards to be able to help understand what the marketplace and guide the marketplace moving forward. So I would really focus on, thinking about validation as locally as possible, and then building trust, and then transparency, being, brutally transparent as much as you possibly can, and that's how we're going to get better engagement from our communities.
So, I think one of the areas that health systems are overlooking is educating patients on how to take their medical records and use that with publicly available AI tools. Because, I think as we've heard already across other panels, that patients are already doing this. So I've had a number of patient advocates increasingly come up to me in the past few months. I'll share one story, but it's similar across all of them. They get, a CT done or an MRI done, and they'll take the images and they'll load it into one of the publicly available, large frontier models or other models, and ask for an interpretation before the interpretation is actually available on the patient portal. And in several of those instances, the ChatGPT or Claude has said, concern for cancer. Right? That diagnosis is coming to that patient from not the provider, but because the patient has their data, they're taking it to one of these models and getting that diagnosis. And so the patient is left, what the heck do I do with this? And so health systems and providers, we need to be educating our patients how to navigate that landscape. What are the trusted sources or resources to use? How do I interpret these results before, the provider even has a chance to talk to the patient? These are, I think, some of the overlooked ways that we need to build better bridges and relationships with our patients as providers.
I said during our preparation for this panel, I at the very end of our conversation, I remember saying to you guys that in some ways I think that we've kind of crossed the trust Rubicon in generative AI. It's a sort of interesting moment for us where there's a lot of inherent suspicion about AI in the beginning. It's trained on whatever, and will it hallucinate? Will it cause problems for me? Will it not be something that I can believe in the future in the process of my own care? Now we have almost the opposite happening. You heard Grace talk earlier about how patients want to use this technology. They are using this technology. It's almost an expectation that the system will provide, as the consumer-grade versions of ChatGPT and Claude and other things advance, it's almost the expectations of our patients and families that these tools will become more available to us. I had another patient advocate, Sue Sheridan, who works with us and has worked with us for a long time in patient safety. This is one of the world's leading patient safety advocates. And Sue said to me, I will never, after having a misdiagnosis in the emergency room and then using ChatGPT to self-diagnose, she said to me, I will never go to a physician who does not at least express the intent to use AI in the process of my care. This is from a leading patient safety advocate. We've kind of flipped the whole equation here around trust. I think that we in some ways trust the AI, not so much more than our providers, but we are absolutely trusting providers that use this technology to enhance their diagnostic decision-making and their therapeutic decision-making more than providers that have chosen otherwise.
Well, to stay on this topic, a lot of what we've been talking about is what types of policies are appropriate to get the balance right between innovation and trust and safety for health AI. I think the other thing, Brian, that you had brought up, which reminds me, is what can AI do for policy? And as there's growing concerns that we may have more Americans that go uninsured, right? Going to these large language models, these chatbots, to triage medical symptoms, should I seek care, should I not seek care, or, to augment navigation through the system. Increasingly for a lot of these Americans, it will be their primary source of not medical information, but in some ways medical care. And so how do we think about this future state where it's not, using an LLM to decide if I should go see my urgent care or primary care, but as a replacement perhaps for going to the emergency room? How should we think about this as an alternative to traditional healthcare as opposed to an augmentation?
So, again, I'll start with I'm an optimist. I am really actually excited about it. I think one of the things I remind folks, in medicine, we have to graduate between 2 to 3 classes. Like most times it's 3 classes of medical school students just to replace those that commit suicide, because that is the burnout issue that so many providers face. So we are not going to hire our way out of the access and shortage problem. We need this kind of tool to be able to help reach patients that have to wait 3 months to see a primary care doc to take care of their diabetes in a rural environment or drive 200 miles. And so I think we need to create the kind of policies that enable those that are in rural America, that are in inner city America, to be able to have better access in a timely way to take care of the chronic diseases that they're facing, right? Like the agentic future that we need to live in is one where we have trusted, LLM-powered agents that are helping to manage a diabetic patient or a patient with a hypertensive issue. Because I don't want that patient to have to wait 3 months to see a human being and end up in the emergency room, right? Like that's what we want to avoid. And so, I'm really excited about that future. I think, maybe I'm in the minority of physicians, but I think there's an inevitability of moving in that direction where we're not going to solve it with hiring more physicians or nurses or NPs. We need this kind of tool to address, decreasing life expectancy in the United States. Like that is a huge issue. I think agentic AI is part of that solution.
I guess I would say it's already happening. On some level, it's been happening for a long time that people have been using, internet-based tools to augment their understanding of their clinical scenarios and situations. I wouldn't for a second, Bakul is here from Google. People have talked about Dr. Google for the last 20 years, on some level. And I think that is, yes, there are differences in using a chatbot or a chat tool, which, on the positive side has tremendous capability, can reference, the medical literature in sort of very impressive ways. On the negative side is, has a real problem with sycophancy, and sort of, sucks up to us and tells us exactly what we want to hear. So if I have a brain tumor, it's going to tell me that I have a brain tumor or help me understand that I have a brain. If my pretest probability was low, but my prior belief was high that I have something, I can coach the chat to tell me what I want it to tell me. So I think there's some real challenges and issues with the technology, but there are, we've been doing this for a long time. And the fact that this tool is now in our environment, our patients are going to use it, and we should be helping them to understand how to use it. For me, it's not necessarily about, it's not educating otherwise, it's sort of helping people, coaching people to use this technology successfully in their care.
Yes, question from the audience.
Last time I asked about what would be the wish of the panelists. What's your biggest concern for the next 6 months? Something that could happen that would be a big negative for this, or developmental, whether it be policy or headline or those sort of things. What are your concerns over the next 6 months?
Thank you, Sean.
Can we start with Brian?
So I am an optimist. So I have not that, I do have some concerns. I would say the biggest concern is that we don't make the right kind of investments to support the direction where we want AI to go. My hope is that AI is going to be a tool And like every other tool that humanity has created, we've been in the loop and we've authored the next chapter of our future, of what we want our future to look like with that tool. I think there's a risk with AI that we sort of say, okay, AI, you got it, right? We're going to take our hands off the wheel, as it were. I think there's real risk when it comes to our health. That is a very intimate and personal thing, right? My values, my definition of what it means to live a complete good life is very personal and intimate to me. And so how we think about these AI models being able to understand that and allow that to flourish and thrive, I think there's a risk that we don't do that right.
Well, for me, we've been kind of talking about it already, but I think there's a very real possibility that we end up with a two-tiered or multi-tiered health system. We kind of have that already to a degree. It would sort of be more of a reinforcement of the exacerbation between those that have and those that don't, with AI tools sort of serving the ones that do have and us sort of leaving the other systems in the dust. I think that's a real risk, and some of what we've been talking about here on the panel is how to mitigate against that risk, by building, shared partnerships across the ecosystem, creating, hubs and consortia that can distribute these technologies, actually funding in a proactive way, real material opportunities for systems that are under-resourced to be able to buy into these technologies and use them in their environment. But I think there's a very real possibility that we have at least a two-tier and likely a multi-tier system where AI tools are used for the advantage and not for those that don't.
Yeah, and my answer is kind of combining the two, Kadar's and Brian's answers. We are at a really pivotal time with the Rural Health Transformation Fund and the opportunity to really innovate and modernize health IT in rural communities in a meaningful way, which is so incredibly exciting. I mean, $50 billion to think about how are we driving connected care in communities that have been left behind. The opportunities for a miss or a fragmentation with solutions that maybe one-off could wind up really putting things behind or wind up driving even further digital divide. And again, going back to thinking about meaningful use and the dollars that we put there, it is not uncommon for us to be installing, and upgrading somebody's system and have that be their 5th or 6th EHR, and the amount of post-traumatic stress disorder that they have as a result of that. And it impacts trust, right? If you have had to rip and strip your EMR more than once, you've got scars for it, right? And so you think about, what that means, and if we're not being thoughtful, and we are going to have 50 applications on how we're approaching this. If there's opportunities now to transform, I really encourage us to think about that and making sure that those monies are really thoughtful and that we're building to things that can scale and grow.
Yeah, thank you. I would just add, I worry about trying to do too much too quickly with expectations that may not fit reality. I believe in the transformative potential for AI, but I don't think we're going to see it, in meaningful terms, in terms of productivity or other metrics in the near term. And while vendors will tell us that, and consulting companies will tell people that we're going to see huge improvements, the improvements that I'm seeing are real, but they're not laddering up to the levels of organizational transformation that people expect. And so my worry is that a lack of patience will actually, kill momentum. And we've seen that multiple times with AI winters. It's not the technology, it's just overinflated expectations that have really taken the wind out of the sails. Any other questions from the audience?
Yeah, I also have mixed feeling about the using AI in the healthcare. Right now, what guarantee that you have that doesn't affect the FTE? The reason for it, back in Taiwan, they already using neurobot to combat the nurse shortages. So, and they are successful. So if they're doing it and they have a successful model, what prevents you in here to reduce the staff using robot. And of course, we all remember the time that we used robot in California, in Kaiser, to, inform a patient who's gonna die the next day through a robot what happened. Kaiser got sued because the patient thought this is so impersonal. So what are we doing with this robot business in the future replacing our healthcare workers? And that's a possibility because it's already happening on the other side of the world.
Great. Okay. So I heard two questions. I mean, one was really around, we've been talking about a lot of AI, and much of this is software, but I do think that robotics is another component that we haven't talked about. And then two, I think what we heard loud and clear is concerns around workforce impact, replacement, a narrative that we've heard a lot, doctors have heard a lot for a long time. So how do you guys think about both of those issues?
I'm happy to go first. I mean, there are so many examples in human history where we've created a tool, where we've created something and it's displaced, right? There is a real disruption that happens in terms of the portfolio of work that a nurse or a provider may have to do. A tool says, great, I can take on this portion of that work. And I think that's what we're going to see with AI. The AI and physical AI, be it robotics or otherwise, will likely take on portions of the work that nurses and providers have, but it's not going to replace them. Again, there is so much demand by our patients that I just don't see a foreseeable future where we're going to need to let go of nurses and doctors. I just don't see that happening. But what I do see happening is nurses and doctors being empowered to spend more time doing the things that matter more to patients while letting, a robotic AI maybe handle, in medicine we call it the scut work, whatever that less glamorous, job might be. I think that, but again, it's our choice on how we want that to happen. And so I think the call to action I would urge all of us is like, if we have the ability to author that future, which I believe we do, we need to build that together.
Yeah, I would agree. I mean, I think we have, as you're saying, the historical perspective is every generation of life-changing technology has come with a concern about disruptions to the workforce. And every successive generation, whether it's the steam engine or electric power or the internet, created, yes, job disruption and changes, but really an evolution of the workforce. So if you think about, pre-internet, we didn't have the concept of a web designer didn't exist. Now those people, that is now a job. And we will have now a version of that story, not just in healthcare, but in all industries. We will have new jobs that likely have a lot to do with the things that we've been talking about on this panel, likely have to do with, helping with the messages around trust and the messages around kind of helping with adoption of these technologies kind of going forward. So I actually feel quite optimistic that in the health ecosystem, there will be quite a lot of additional, either it'll be about saving time and increasing productivity so we can address the unmet need, which is vast and substantial in healthcare, and there'll be new roles for us to play to help bridge the trust and equity divides that we've been talking about here on this panel.
Can I just say, I think that's why it's so important at an organizational level, as Jen said, that we work to upskill our providers and our nurses because of that disruption.
Yeah.
Yeah, I can't speak to robots, but I can speak to the chronic shortage of workforce that we're facing and the safety net, and it's not getting any better every day. And need and compassion is always going to be key, and compassion is something that I'm actually excited about putting more of back into the world by driving AI. And people are going to want to work with people. They want to have that compassion back. So I actually am an optimist as much as I, talk about the pitfalls potentially, but the opportunities to be able to bring compassion back into healthcare is one that I'm really excited about. And I think AI can help.
And just to build on that and to close our panel, I would just say that also being an AI optimist, for me, the final frontier is really human touch. It is by far the hardest thing to replicate. It is the last thing humans want to be replicated. If there's any jobs that feel threatened by AI, it's white-collar jobs like me that spend most of my day on emails and on Teams meeting. Like, we know that these chatbots can replicate that type of interaction well. What it cannot replicate well is the importance of human touch and the value that patients place on having a human interact with them, do the things that we would only trust other humans to do. And so I think not only are we a long way off technologically from that, I think we're a long way off from people even wanting that, if that were an option. So with that, I want to thank you for the panelists, and I want to thank you all for joining us today, and I'll turn it back to Cecilia.
Thank you, everybody. Wow, what an incredible note to end on. So I want to thank Dr. Yang and our panelists again for the rich conversation, and I want to thank you for the questions that you came into today with, as well as those of you that got a chance to ask a question using the microphone. So many important topics we've hit on over the course of the day. And right now, really just that last thought around the inability to replace touch, I think is such an important note to end on. So as we close our session, I would like to thank all of the speakers and moderators for the entire day. The discussions were really thought-provoking. The topics we hit on overall were really incredible. I know I spoke with many folks over the breaks just about the importance of the conversation that we're having today. So I want to thank you for being here with us. I want to thank the Institute for Health Policy team, Rebecca and Nani, for leading the development of today's event with support from Ben, Kristen, Renee, Nicole, Alesa, and thank you to our forum advisory group. I believe Daniel sits on that as well, for advice and assistance as we were putting today together. I want to also thank the team that helped us host today's event, Marilyn, Wendy, Diana, Wayne from our Center for Total Health, Spark Street Digital, our partners, our photographer, Rodney Bailey, Lawson Catering Group, and many others. So thank you to all of you today, especially for being here, for participating in the rich conversation that we've had over the course of the day. Please take a few minutes to complete our event survey. You can access that through our event webpage or the QR code displayed on the screen. Your feedback is so important to us. It helps us think about these events, the topics that we're going to be touching on, and make sure that it's addressing a need that you all help us identify. The full recording of the event, including individual sessions, will be available on our website within a couple of weeks. And with that, we are concluding today's event. Thank you again, everyone, for being here with us today, and safe travels back home.